Hopefully we'll have a productive meeting. I want to start off by asking Chairman Walker if he'll open us up with a prayer.
Good morning. Bow with me, please. Heavenly Father, we thank you for all the blessings of life. We thank you for your Son, Jesus, and the grace and mercy you give us. We thank you for this beautiful day. We pray traveling mercies for all the people that are here today. We also, Father, want to lift up the farmers and communities in South Georgia as they are dealing with the aftermath of the recent hurricane, Lord. Please give them strength and hope and resolve to rebuild and recover, Lord. All these things we pray in Jesus' name, amen.
Amen. Thank you. So we've got a big agenda today. Before we start, I want to thank a couple of people who are in the room. Bernita, my assistant, who's really done a great job putting all this together and getting us all here. John Chapman as well. Most of the speakers have heard from him. The two of them have really taken this on, and we wouldn't be here without them. So I want to give them just a round of applause and thank you all very much for all your help. Thank you to Northeast Georgia Health System. Blake, thank you all very much for hosting and for the coffee this morning. And for everyone else that's here, if I start thanking everyone, I know I'll leave someone out, but very appreciative for y'all making the trek up here. Hopefully the traffic wasn't too bad. I think you're normally going the right way with traffic coming up here, but we've got a number of speakers today, and what this study committee is going to do is we'll first start off with this meeting kind of taking a broad approach, identifying some issues that we're seeing across the state in rural areas, and I guess trying to pinpoint things that this committee believes the state can help with. And then as we move forward, we'll take a more surgical approach, no pun intended, with some issues that we identify that we're particularly interested in. I know we have set our second meeting for October 24th at Medical College of Georgia. I want to thank Megan Brass for helping us with that. And then we'll have a third meeting in November or December. We're looking at some availability with the committee members. But before we turn it over to our speakers, I just want to give the committee members a chance to introduce yourselves. So we'll start down here with Senator Kirkpatrick.
Hi, I'm Kay Kirkpatrick, Senate District 32, which is Cobb and Cherokee counties. I'm a retired orthopedic surgeon and vice chair of the Health Committee.
Hi, I'm Kim Jackson. I represent District 41, which is in DeKalb and Gwinnett counties, and I am really glad to be on here. I also serve on HHS as well.
Good morning. Good to be with you. I'm Nan Orrock in the Senate from representing voters in Atlanta and the Tri-Cities area, Hateville, East Point, and College Park. And I've served on the Health Committee in the House for decades, and now I've been on the Health Committee in the Senate for decades. We've got important issues facing us, and I really appreciate our chair's leadership on convening this effort. Thank you.
Good morning again. Larry Walker. I represent Senate District 20. Live in Houston County, but represent 8 counties across Middle Georgia. Chair the Senate Insurance Committee, Insurance and Labor. I'm also on the Senate Health and Human Services Committee, and glad to be with you all this morning.
All right, thank you very much. Today we're going to kick it off with a former colleague of ours, Dean Burke, with DCH. Dean, if you want to come up, and there's a microphone right there. And we've got a list of speakers here today. We'll open it up to public comment at later meetings, but Dean, we'll turn it over to you.
Good morning. Thank y'all for having us here. First off, I appreciate the opportunity to speak. I want to give you greetings from our brand new commissioner, Russell Carlson. And Russell, upon taking on that role, gave me the honor of overseeing our Office of Rural Health out of Cordele, and those are the folks that are going to be presenting here today. I'm going to let Brandy introduce them. But Chairman Hatchett gave me the permission to get off target for just a minute to just make an announcement. There's several people in this room that are on my list to call and remind. There's a process called revalidation that the state has to do for anybody that's a Medicaid provider. And revalidation basically means you're telling CMS and the state that you still want to participate in the Medicaid program and that you haven't committed a felony since the last time you revalidated and that you're still eligible to be a Medicaid provider. And it's just one of those nuisance things. If you're a physician working in a hospital, and we've got a few around here, your dad somewhere, there he is, you know, even though we've been in the same place for 30 years, every 3 years we have to fill out paperwork and remind people that we still want to participate in the hospital world and sign all of those affidavits saying that you're still eligible to be a hospital member. So it's not an unusual process, but as of the 1st of August, there were still 70,000 providers in Georgia that had not done their revalidation. So some of those are multiple practice sites, so each site has to be revalidated on its own. You can't do it one time. And we just want to remind everybody that deadline is September 15th. And if you don't revalidate and you bill Medicaid, that claim will be denied. So, you know, there is a financial cost to this if you don't take that 15 minutes to go in the system and revalidate. So just wanted to, anybody that has contacts in that provider world, make sure you get the word out that needs to be accomplished and that the deadline is quickly approaching. So, but going to the subject matter of today, obviously, you know, my career in medical practice was in rural part of Georgia, and then my service in the Senate, that was always a primary passion of mine, and so this subject matter is dear to my heart, and I really do appreciate your taking on this very, very challenging role. This is not a simple solution. Workforce issues are broad around the country in all fields, but obviously in healthcare it's got particular ramifications that maybe others don't. So thank y'all for that. And with that, I'm going to introduce Brandy, our Government Relations Director, and let her introduce our speakers.
Actually, do you want to sit here so you can see your presentation? Okay. Thank you, Dr. Burke. Thank you, Chairman Hatchett, members of the committee. As Dr. Burke said, my name is Brandy Sylvan. I serve as the Government Relations Director at the Department of Community Health. We certainly appreciate you guys taking some time to dive into this topic. It's an issue that we hear from our providers and our members on a consistent basis as being a challenge. As you are all familiar, Governor Kemp, kind of emphasized his prioritization of this topic when he established the Healthcare Workforce Commission last year. Our DCH commissioner at the time, Kaylee Noggle, served as the chair of that committee. And Nita will talk a little bit about some of the recommendations that came out of that commission. So Nita Ham serves as our senior director over at the State Office of Rural Health. The federal government requires that every state have a State Office of Rural Health. So ours is in Cordele, Georgia. And Nita will give you a little bit of an overview about that office as well and their role. Thank you for having us, and we'll be happy to answer any questions you have afterwards.
Thank you. Thank you. I'm so happy to be here to be able to present information to you from the perspective of the State Office of Rural Health. So I just wanted to give you a little bit of information about our office. We are the State Office of Rural Health, which is a division of the Department of Community Health. And as Brandy mentioned, this is a requirement of the we were funded by a federal program. There's a State Office of Rural Health in all 50 states, and our office was established in 2000. And as she mentioned, we are positioned appropriately in Cordele, which is in rural Crisp County. We have 4 program sections in the SOAR office. That's the Primary Care Office, the Farm Worker Health Program, Hospital Services, and the SOAR program. We're a small office. We're a staff of 10 people, and we manage 6 HRSA grants for which DCH and SOAR are actually the grantee. And those grants provide funding for the office management and for salaries for our staff and for other programs, okay? But our overarching responsibility at the SOAR office is to effectively and efficiently administer federal and state-funded grant programs that are intended to increase access to quality health care, improve the quality of health services, and promote the health and well-being of our rural residents. And so our funding every year fluctuates a little bit, but in fiscal year 23, we actually managed a little over $27 million in our office for grant-funded programs, and you can see that it's broken down into a little over $9 million of federal dollars, and we had about 17.7 and some change in state dollars. And we're quite a busy little group. I did a count of the active grants we had as we actually went into fiscal year 24, and as of July 1st, we had 76 active grants and 18 active contracts that were distributed between and managed among our 4 program sections. So just to give you a little history about, or a little visual rather, on rural Georgia. And this is one of my favorite maps because it's a great visual that actually shows just exactly how rural Georgia is. So as you know, we have 159 counties, and 120 of those are defined as rural, having a population of less than 50,000. But out of all the people that lived in Georgia, there's only about 26% of Georgia residents that live outside of our urban centers. And every year, our rural populations continue to decline. However, we have a higher death rates and death rates for heart disease and stroke and cancer and motor vehicle accidents, and certainly an increased prevalence of chronic conditions. So this is my second favorite map, which gives you a little visual on our rural hospitals. So in our 120 rural counties, we actually have 67 small rural and critical access hospitals, and those are broken down into 37 rural PPS hospitals and 30 critical access hospitals. Now, one of those critical access hospitals actually does reside in a county that's not defined as rural. That's Effingham County, and it has a population greater than 50,000, but we still include that hospital because of its cost status. Now, this map also shows that we have 54 counties that do not have hospitals at all. So I realize the map's a little bit busy, but our rural hospitals are identified in green and purple, and then the counties with the red X have no hospital. And the reason I wanted to point this out is because we have clusters of counties that have no hospital anywhere in sight. So if you notice toward the western sort of central area, you can see large clusters of counties with no hospitals, and then in the bottom of the state, in the southwestern quadrant there, we have a rural hospital in every county. So having clusters with no hospitals, and clusters of counties with a hospital in every county actually creates its own challenges for both workforce and healthcare access. So just to talk a little bit about the workforce, as Brandy mentioned, I'm going to lean in a little bit into the report that was provided by the Workforce Commission. And as she mentioned, this was the commission was established last year by Governor Kemp. There were 15 members, and it was chaired by our former commissioner, Kaylee Noggle. So I believe they met each month from July through December, working on this report. And what I'm actually going to focus on and refer back to from time to time is the part of the report that's actually the commission recommendations. So as I get ready to talk about that, I do want to tell you a little bit more about what the SOAR office does already to address workforce issues. So as I mentioned, one of our offices is the primary care office, and I actually have the director of the primary care office came with me. Beth Walker is in the back of the room, and in the handouts that we've provided, there's a lot more information about what they do. They actually have a lot of responsibility in the PCO office, and I'm just going to hit on a few things that they manage. But one of the things that the PCO office is responsible for is health professional shortage area designations. A few other things they deal with is the National Health Service Corps program, the HRSA Georgia State Loan Repayment Program. They manage the Conrad 30J1 Visa Waiver Program. And then the PCO, the SOAR PCO, is actually the designated state administrator for the 3R Net program, which is the Rural Recruitment and Retention Network. So just to give you a little bit of information about HPSA, or Health Professional Shortage Areas. So the definition by HRSA is a shortage of primary care, mental health, and dental health providers in a geographic area, population group, or facility. And there's specific criteria, scoring criteria, in which they calculate these scores. And the scoring criteria includes population to provider ratio, the percentage of population that it's 100% poverty level, infant health index based on infant mortality rate and low birth rates, and then travel time to the nearest source of care. So just to give you a quick look at one of our maps, this is actually the HPSA score for rural primary care, and this map is rural specific. It's awfully colorful, but if you'll notice, sort of focus on the tan and the yellow areas. So scoring is required by HRSA every 3 years, and it's the responsibility of our office to update those HPSA scores every 3 years. The higher the score, the higher the need. So this map actually indicates that 88 of our 120 rural counties actually scored in the high levels between 15 and 25. So you may wonder, well, what's the purpose of the HPSA scores? Why is that so relevant? But those scores are actually the nucleus of all of these federal programs. So some of them I've already mentioned, and I'll speak to just in a minute, J-1 visa and the National Health Service Corps. But it's also, the HPSA score is, or the Medicare bonus incentive program is dependent on the HPSA score, as well as the federal qualified health centers and rural health clinics. So one of the programs that we manage that I just referenced, I'll just speak to quickly, and that's National Health Service Corps. And this program is really focused on recruitment and retention. So I've divided it into those two sections to kind of explain this map. But specific to recruitment, if a site in the state wants to become an approved National Health Service Corps site, they work with Beth in our office to complete the applications, and she makes sure that they're complete, and then they submit them for approval. And when they're approved, this actually becomes a marketing tool for that site, because the other half of this NHSC program are loan repayments and scholarship programs. And if a provider applies for those and is successful in getting loan repayment, for instance, then they have to commit to one of those approved sites, and they have to practice in that site for at least 2 years. And so what's great about NHSC is they have to commit minimum of 2 years, but they can commit a little longer to continue that loan repayment program. But what the data coming out of NHSC says that if they stay in that area for 2 years or longer, you're looking at retention rates of those providers of 80 to 85%. So that's really important to look at. Another program that we're managing, which is also loan repayment, is a new program. It's a HRSA program that is a state-specific loan repayment program, and providers that are eligible for this, of course, are physicians, advanced practice providers, licensed clinical social workers, and professional counselors, as well as registered nurses. Now, this is not rural specific, but if they apply for those loan repayment programs, then they have to commit to a particular practice location. So the practice location for those are federally qualified health centers, rural health clinics, critical access hospitals, and then private practices. Now, this is new. This program hasn't fleshed out as much as some of our others, so we don't have a lot of participation yet in that program. We only have 9 rural counties in which we have some of those loan repayment participants, and then 4 counties in which we have participants are urban. Another program that we manage is the Conrad 30 J-1 Visa Waiver Program. This program actually allows international medical school graduates who are here in our country on J-1 visa to waive their 2-year home requirement for 3 years of service in the country, in the states. So currently in Georgia, we have 90 physicians that are participating in the J-1 visa waiver program. Unfortunately, only 18 of those physicians are primary care. The other 72 are specialists, and I say unfortunately because we typically don't attract a lot of specialists into the rural communities. So we have 19 counties in which these 90 physicians are hosted, and again, the majority of them are specialists, so they are located more in the urban areas than in the rural counties. Now, our office offers a lot more than just loan repayment and scholarship programs. We actually have, as I mentioned, when we started FY24, we had 76 active grants. And those grants, if we were to look at all of those grants and kind of divide them into buckets, we support our rural health care basically in these 6 ways. So some of those programs are dedicated to financial and operational improvement, which is certainly beneficial for our healthcare facilities, quality improvement initiatives, continuing education initiatives, service line expansion for hospitals and clinics, telemedicine programs, and addition of primary care clinics in rural areas, all of which are very important. And the column on the right basically is some examples of those programs that fit into one of those 6 buckets. So we have revenue integrity and solutions programs, wing bed management program, patient-centered medical homes. We also fund the area health education center, which is really the statewide pipeline for getting folks out of interested in healthcare careers as they're in middle school and high school. And then we have some unique programs like the electronic intensive care program, in which we have rural hospital ICUs that are directly connected through electronic means with Emory University and have access immediately with critical care specialists. So we're really proud of all of our programs. And there's one more program that I want to mention, and that is our Rural Hospital Stabilization Grant Program. And I want to bring this up not so much to talk about the program, but to talk about a lot of the information that we get from our hospitals who are participating in this program. So just to give you a little backstory on the program, it's a legislatively directive program that we started in fiscal year 2016. We're actually in our 8th year of funding, and to date, we've had 35 rural hospitals that have participated in the program. So that's a little over half of all of our rural hospitals that have been involved in the stabilization program. And some of our hospitals have actually participated multiple years. So far, we've invested a little more than $45 million in that program, and those hospital leaderships, many of them will tell you that that funding, during that funding period, actually made the difference between the hospital being able to stay open. So we're very proud of that program, and currently the participants in the program, grantees, are selected through a standardized application process. And one thing I want to mention about that program is that it has very specific goals, objectives, and guidelines. So as the hospitals submit their applications for the program, before those grants are executed, they present their proposals, their use of funds proposals, to our office. We review what they're proposing to ensure that they meet those guidelines. And then during the funding period, which is typically about 1 year per funding cycle, there is a lot of technical assistance and interaction with those hospitals. So they are all brought together at the beginning when the grants are executed. I meet with the project managers every quarter. I provide a huge amount of technical assistance individually to those hospitals throughout the funding period. And then at the end of the funding period, we bring them all back together, and they get to present their projects to each other and talk about some of those successes as well as challenges, and share some of the things that worked for them so that other hospitals can consider some of those initiatives themselves. So I bring this up because I wanted to mention some of the benefits that we have found, not so much about the funding itself, but about some of the things this program has taught us. So the benefit to the grantee is that we recognize the uniqueness of each rural community. And if I've learned nothing in the 10 years that I have been at the State Office of Rural Health, is that no two communities are alike. They may be very similar through demographics or in their geographical location, but they're all very, very different, and solutions to their problems are usually very individualized also. One of the other requirements for this grant program is that they are required to have community engagement. In order to take the funds, they have to engage their communities. In the early years of the program, it was a little bit uncomfortable because our hospitals were very used to working in silos, but once they were required to get out into their community and to reestablish relationships and sometimes repair some reputations and actually get involved with the community and let the community have a voice in how those funds are used, the difference has been enormous. And many of our hospitals say that that particular piece of this program, the community engagement and the reconnection with their communities, has really been very, very successful. Hospital leaders, one of the other things that this program has proven is that hospital leadership really is best to determine the prioritization and the direction of their funding based on their individual needs. So again, when they apply for the program, they have to provide us with data and stats, and they have to explain to us what internal resources they used to make the decision on how they wanted to use their funding. So we actually have a little glimpse as to what their decision-making process is. But we leave a lot of those decisions up to the hospital of how best those funds would be used. Now, the benefit to our office in the last 8 years during this program has been enormous, because what we have done through this program is establish some really, really strong relationships with these hospitals and their communities. So we have gotten to see the struggles and to see their needs through their eyes by being so connected with them through this program. It also has engaged our staff in rural healthcare problem identification and recognition, and it encourages a very forward-thinking, solutions-based approach to new initiatives that may be offered through our office, especially when we have new funding and we can look at what those hospitals need and direct that funding into appropriate ways. So it really helps keep us in the know. A couple of things I wanted to mention about 2 meetings that I've had with our hospitals over the last couple of years. In May of 2022, we were getting close to the end of what I refer to as Phase 6, the 6th cohort of grantees that we had in the program. And that year was unique because we had the largest number of hospitals participating in the program. To date, we actually had 16 hospitals participating, and you can, they're identified on the map, so you can see we had a good scattering of hospitals across the state, north to south. And as we were getting ready to bring them back together, we thought, we've got a really unique opportunity here, because we've got almost a quarter of all of our rural hospitals participating in this phase. So when we bring them back together, we can really do a deep dive and collect a lot of information from those hospital leaders as we bring them into a very intense 2-day workshop, locking the doors so they couldn't leave, and we could make the best use of their time. So we decided this would be a great opportunity for us to offer a very detailed survey, as well as break them into small groups. And Mercer staff, as well as Draffin and Tucker accounting firm, worked with us to develop the workshop. So we partnered with Mercer to design our survey, and they also ensured that it was a valid survey. There was a total of 127 questions that were divided between 12 categories, and the number of questions per category ranged from 4 to 32. They were presented randomly, so we were not driving anyone's responses in any direction, presented in a Likert scale, and it was all real time. So as they sat there for 127 survey questions, they were able to see the questions as a group and then respond to the questions as a group and see where their responses fell. So we had about 45 leaders that were all in the room at the same time: CEOs, CFOs, CNOs, project managers from representing those 16 hospitals. And what we really wanted to know at the end of the survey and through those small group discussions is, what are the top 5 things that our rural hospital needs? And so from their mouths to you, these are what they said were their priorities and their challenges for these rural hospitals. So number 1 is just cash flow, cash on hand, cash reserves. It was just cash. And then the next 3 bullet points are all focused on staffing. So it was finding them and keeping them, and keeping the costs down, because in 22 we were coming off the heels of COVID, and so many of our hospitals were financially stressed during that period, just trying to pay the high costs of staffing services. So, and then at the 5th bullet point there is keeping and increasing their market share, because that's what's important to those rural communities. That's why the community engagement piece was so important. You want to keep those rural residents coming to their local hospitals for their care and prevent the out-migration where they're going 2 or 3 counties over. So we wanted to make sure that they have money to keep their doors open and that they have the staff to serve their patients, because they certainly want to make sure that their communities are using their hospitals. Now, in July of 2023, not too long ago, we brought in the 7th group of 10 different hospitals, and we basically had the same response. The only difference for that group is that those hospitals during 2023 had begun to wean themselves off of those high-cost staffing services. They were beginning to get a little bit stable in that respect, but that was still, weaning off of those high-cost services was still as a result of very, very aggressive recruitment and retention efforts. So that's what the hospitals have brought up to us, and certainly recruitment is one of the, recruitment and retention is one of their big issues. So now I'm going to lean back against the Workforce Commission's document. A couple of things that I had found in that document that I thought was very interesting. Georgia's growing demands for healthcare services are primarily driven by overall population growth. But remember, that's not the case in our rural areas, because that populations in the rural areas are declining every year. And then the aging population, so residents over the age of 65 are growing faster in Georgia than in any other state. And certainly the large majority of our residents in rural areas are greater than 65. And then, of course, this leads to the increase of disease burden, which certainly speaks to the need for higher engagement of those healthcare professionals. A couple of other interesting things that were pointed out in the workforce is that the workforce itself is trained largely by public and private post-secondary institutions, and 50% of our healthcare are actually being trained, of the healthcare graduates are actually coming out of 20 institutions. And Georgia only retains a little more than half of those healthcare graduates. So we're losing 3.7 workers each year by that are not replaced by those graduates. So when you look at the information that's provided in that workforce report, and then you go back to the information that we're collecting from our hospitals as they sit with us around the table and talk about their struggles, one of the things we talked about is their current workforce status. So these are the folks that are currently working for them. Two things. One is that that workforce does want market analysis, salary adjustments, and competitive hourly rates. They see the recruitment and recruitment efforts to bring in new staff with sign-on bonuses and all of the dollars that they're throwing at getting new staff. And so you've got your loyal staff that are sitting there saying, what about us? We want fair market rates, and we want retention bonuses. We stuck with you through COVID, so we want to be rewarded in that some way. So again, in trying to balance that out, it's causing financial stress on the hospitals. And there's still the post-COVID burnout. We were never at fully staffed, especially in our rural areas prior to COVID, but certainly after COVID, those staffing struggles have continued to increase. And the workloads are intense. There's just the physical and emotional toll because everybody's just very tired. And another interesting point to make is that 20% of our current workforce are greater than 55 years old. So even if they stick with their jobs in those rural hospitals until they decide to retire, we're going to lose a lot of folks just from through retirement. Now, when we talk about the younger workforce, and that was definitely a popular conversation in our hospital meetings, because the younger workforce is is motivated very differently than my generation, and they are more interested in the highest hourly rate possible and not so much interested in benefits packages. And they're not usually coming to work for you because they're looking forward to that retirement dinner and the gold watch. So they're not going to stick around nearly as long as they used to. Our hospitals tell us that they feel very fortunate if they get a new incoming employee that stays with them for a couple of years, which may mean at some point in the near future we need to redefine our definition of retention and start working toward new retention initiatives with a different expectation. So they're also very, very interested in flexible schedules. They really focus more on their work-life balance. So they're very interested in kind of tailor-made schedules that will work with their personal lives. And they are interested in continuing education. So they very much want to expand their fund of knowledge and skill set. But keep in mind, continuing education provided to them makes them much more appealing when they decide to go look for another job at another hospital. So they did tell us, though, that employee satisfaction is not always about salaries, that Definitely some of the information they've gotten back during satisfaction surveys and in talking with their staff is that the quality of supervision and management is extremely important. And they really want updated facilities and equipment. They want to feel like they work for a facility that has that is equal to those larger hospitals in the urban areas. So they love having updated facilities and equipment, cutting edge environment. They want positive environments to work in, comfortable break areas. And for those that are planning to stick around for a while, they're also seeking promotion opportunities within the hospital. And again, flexible schedules is very important to them. So they feel that personal satisfaction, professional satisfaction in working with those hospitals is really about feeling valued and respected by the leadership. They want to be involved in the decision making. And as our hospitals got their stabilization grants, they often involved their staff and their supervisors in making decisions about how to use those funds. So going back to some commission recommendations now that we've sort of I've spoken on behalf of the hospitals as far as what they're needing, recommendations by the workforce study is specific to optimizing the current healthcare education system, because if we're looking for new staff, that's where they are. They're going to be educated somewhere, and that's who we're going to be tapping into, are those folks who are not yet in those programs or in the programs with the potential to graduate pretty quickly. So looking at quick start programs for healthcare is certainly an option, exploring earn-to-learn programs, looking at faculty incentives, and then as far as attracting new workers, optimizing marketing of dual enrollment opportunities for healthcare fields for high school students, and then creating additional scholarship programs other than what we already have on the table for healthcare. So again, when you go back and look at the conversations that are going on with the hospitals, they agree with all that. They realize that their workforce is right there in their community, in high school, or in their local educational institutions. And the technical college system is very widespread, especially in the rural areas. The technical colleges are pretty easy access, and they value those technical college programs. The nurses that are coming out of the LPN programs and the 2-year RN programs are just as valuable to them, not to devalue 4-year programs or any graduate programs, but they need workforce quickly. And they recognize that that's where their workforce is. They're in the high schools, in their own community. And those technical colleges produce a wide variety of other allied health programs, and they need that staff too. So they also agree that it's important for them as a community to support those quick start pathways, such as the work-based learning. College and career academies, which are part of the technical colleges, are very popular in some of our areas, and that's really where they're building strong relationships. Dual enrollment programs now. You can tell I'm not a youngin', so sometimes I get a little nervous that we've got kids coming right out of high school that have LPN license and are going right into the hospital to start practicing. But that's what we need. We've got to get people into the hospital as quick as possible. So they recognize that they have to grow their own, and because they've developed these relationships with their communities and when their schools. These local schools, they're getting out and being visible. They're having community engagement initiatives. They recognize that they've got to get engaged. They've got to set up community events that are going to bring these young folks in. They need to go be present in the high schools, arrange hospital tours. We've got some pictures. The folks that are all in their PPEs up there in the top are all high school students that were at one of our hospitals for a tour, and then the health fairs is another way. But hospitals recognize they've got to be creative. They've got to keep up with these young folks, and they've got to get them interested in healthcare. There's a lot of other competing professions for our young workforce, so we've got to make healthcare sexy so that they're going to want to be part of the healthcare workforce. Now, I know this is a broader picture than just healthcare, so to give you a list of some of the things our office always deals with that are barriers to healthcare in rural communities, there's the ongoing conversations about transportation challenges. And I'm not talking about just emergency medical services transportation challenges. That's a whole other conversation. But this is just transportation to and from a doctor's appointment or someone that gets discharged from the hospital and then doesn't have a way home. So certainly those are huge barriers in being able to keep our rural residents healthy. Broadband and connectivity is another challenge. We still have pockets in rural areas where connectivity is very poor, and as we lean more and more toward solving some of our healthcare problems in rural areas with telemedicine, it's so important that broadband and connectivity be accessible and available, and that we can continue to provide those connections with specialist physicians or physicians that are not within a community through telemedicine. So we need some work in our connectivity in rural areas. And then just in general, lack of business and industry growth. As our rural communities dwindle and the businesses dwindle, it's really difficult to attract new providers into rural areas and to attract young families into rural areas, and that's really what we need. And of course, nutrition is very poor. We have lots of food deserts in our rural communities. So all of this, of course, contributes to our problems with quality health care in rural areas, and our shrinking rural population certainly doesn't help. So in summary, what I would like to say to all of you is that our rural communities are really resilient and resourceful, and our rural healthcare leaders, especially in the last decade, have really gotten skilled at prioritizing needs and dollars. And they are having to play the shell game sometimes. They've got more needs than they have dollars, but they have to figure out what is the best use of those funds. And what we've really learned is that a lot of the solutions to these challenges are very community specific. So the recommendations have been provided not just by the Workforce Commission, but by a lot of other research and other reports that are out there. The communities just need to take these recommendations and develop action plans. But we know that if they're given funding and objectives and guidelines, these rural hospitals in these rural communities very often can figure it out. So just to personalize this a little bit, I've got a couple of pictures of some of our rural hospital leaders in some recent meetings that we had in the last several months. So they are all ready and willing to take on the challenge, and as hard as it is, they keep showing up every day and going at it again. Next slide. So that is it for the State Office of Rural Health, and I want to tell you again how much I appreciate this opportunity on my behalf, as well as Beth Walker, my partner in crime in the back of the room, who is the director of the Primary Care Office and does a lot of that work that I had mentioned at the beginning of the presentation. So thank you very much.
Well, thank you for that presentation, and I want to open up for questions. I know Senator Kirkpatrick may have one.
Thank you very much for your presentation, very thorough and much appreciated. My question has to do with something that always bothers me about state government ever since I got here, and that is the silos that we work in. And so the question that came to my mind while you were speaking is, how does HRSA grant funding fit together with the Healthcare Workforce Board, which of course is a separate entity than the Healthcare Workforce Commission? I just want to make sure everybody's working together, and was curious about how you're making sure that happens.
Right, and I am not sure how many HRSA-funded programs the Workforce Board actually manages, but you are correct. We have to get together so that we can see what we're doing and not duplicate or replicate initiatives that are out there. And our goal in the near future is to break down these silos. Dr. Burke and I have been talking about that in the last several months, because we don't need to be tugging on opposite end of the rope. We need to look at this as a relay race so that we're all running in the same direction for the same reasons. So yes, we do. We are and Beth can probably speak to that a little better than I can. She has more working relationship with the healthcare workforce. But we are definitely planning to work with them so that we can compare notes as we move forward with these workforce initiatives.
Senator Orrock.
Thank you, Mr. Chair. Thanks for your fulsome presentation and all the documentation. I had some kind of small questions and maybe some overarching ones. I guess I'll start with the HPSA scores. 88 of 120 rural counties score between 15 and 25. But what's the larger picture? What's the table of scoring? And what does 25 mean in the world of these scores?
25 is the highest based on that scoring calculation that I had mentioned earlier. So that would be the highest need for primary care providers.
Oh, the highest need, not the highest
need.
performing.
Correct, the highest need. So those 88 counties that are scoring between 15 and 25 are demonstrating the highest need for physicians in those areas.
Thank you, that's helpful. The National Health Service Corps, how competitive is that approval process? You described working with hospitals to get the applications completed, and do a lot of them get declined? Do we get 100% acceptance, or how are we standing with working with that program, National Health Service Corps?
Well, Beth is actually the director over that program, so if you don't mind, I'm going to let her address that particular question.
Thank you.
Thank you very much. Yes, we work very closely with all
Will you pass her the microphone so that we can, because we're streaming? Thank you.
Now, is that better?
That's better, thank you.
Okay. We work very closely. My office does, especially myself. We work with the sites to get them National Health Service Corps approved sites. And I would say in Georgia, 85 to 90% get approved. And then when the next application cycle rolls around, they can reapply for approval if they don't get in the first time. And then the funding for National Health Service Corps, we take what the federal government gives the recipients, and we score from the highest need down. So they start with a 25, which is your primary care, and then they fund those programs till the funds are exhausted. But they usually can fund down to about a 14 HPSA score for anybody that's interested in loan repayment.
And so, what's the final result in any given year? I mean, how many NHSC people are in our state working in these settings?
Right now, we have over 200 recipients in rural counties that are receiving National Health Service Corps loan repayment. And and total funding for National Health Service Corps for 2022 was over $14 million.
Federal funding?
That's correct. Federal funding.
Uh-huh. And you pointed out that when people commit beyond the 2 years, they're putting down roots typically, and you can count on a good retention rate when they learn the charms of small town America.
That's
right.
Exactly.
But is there more opportunity there for us? Is that a place that we can see growth if we leaned in on it?
Absolutely, we sure can. And my goal is to get the word out to these eligible sites like critical access hospitals to take advantage of this program. And we also have the Nurse Corps program that's federally funded.
Uh-huh.
And RNs and APRNs can apply for loan repayment. So I'm wanting more critical access hospitals to take advantage of the National Health Service Corps so that they can benefit from this recruitment program.
So that would be a place for us to look for ways to help drive that participation rate up.
Yes, ma'am.
Nothing spends as good as federal money that not eating into our. And the Rural Hospital Stabilization Grant Program. Thank you so much for your. Now this is where contributions get made. Why don't you break that down a little bit on the Stabilization Grant Program, how that
So that's
works.
state dollars.
That's right.
And
Yeah, we set it up.
Exactly. And so we look at the dollar amount that we get every year, which does fluctuate a little bit. And what we've learned in the first 5 years of the program, where our funding's dollar amount per hospital sort of went up and down, is that the the sweet spot, so to speak, of funding for hospitals. To be able to do something really productive with the funding is somewhere between 750 and 900,000 per hospital. So depending on the amount of funding, we look at how, if we stayed in that range, how many hospitals could we support, and then every year we determine the number of awards based on the total number of funding, and breaking it down, dividing it up into the number of hospitals that would give them somewhere in the $750,000 or $800,000
And so
range.
what are we putting in annually? I know
It fluctuates.
Fluctuates, yeah.
When we had the 16 hospitals in Phase 6, we had 15 million that had gone into that funding for that year. It dropped to 9 million the next year, and we're currently for FY23 funds, which is what we've just opened up, we're at $7 million, and then I think in FY24 we've dropped down to $2 million in the budget.
So the program's not working, is it? If we keep on cutting the money, is the money being cut? You didn't cut the money, I know. There are people that we all know who cut the money, but is that a measure of it being an ineffective program? Therefore, the money's reduced, or
I would maybe want to look at Dr. Burke to speak to that a little bit.
he does have a knowledge of that.
Well,
Give them to
it's,
understand.
I think there was a lot of, I wouldn't say confusion, but the DPP program that came in this year was one of those kind of, we're giving money from this hand, so maybe we'll lower a little bit from this other hand. So I don't think there's any doubt that the hospital stabilization money goes to good use, and that it's been a very, very successful program. It's just a matter of priorities and making sure that I don't think anybody wants to give money where it's not needed, but I don't think the rural hospital system is there yet. I mean,
They're not flush. We
They're
would
not
all
flush
agree.
with
Yeah,
cash.
we're not, yeah.
Yes.
Right, so that, again, that's something to maybe to highlight, of looking at, reinvesting in that area and helping us connect the dots on how that addresses retention and new blood and so on and so forth, would be helpful. It's the other question I had is that the 45 leaders from 16 hospitals that you convened and locked in a room. Congratulations. Cash was their number one. Did any of them connect the dots about that there's all this federal money if we expanded Medicaid that would come down into our state coffers and into our health system?
I don't think that was part of the discussion. That 2-day workshop had some very specific focus on in the small group discussions, and that really was not one of the topics that had been brought to the group to discuss. So I really can't answer whether that was on the minds of those folks. It just wasn't something we discussed during that particular workshop.
Well, there's a lot of money on the table up there, and other states are getting our tax dollars. Finally, and I'll stop. Thank you, Mr. Chair. But you gave us a lot to think about and a lot to drill down on. Does the certificate of need, yes, she said it, does the certificate of need debate come into play here? This whole thing of retaining your patient base and delivering services to the folks, in your locality, and has that surfaced in terms of the plight of rural hospitals, the challenges that they're facing?
The SOAR office really doesn't have, we're not really engaged with conversations related to that. Those conversations go on in other areas of DCH. So that's not something that's really on the radar screen in our office, so it's not something that we actively discuss.
Yeah. Yeah, and I'm asking a question that I don't know the answer to. How real or how imaginary is that issue for these hospitals? And finally, Georgia retains 58% of healthcare graduates. That's really worth drilling down on. And under where are they going? They're leaving the state. I mean, that would be a fascinating focus group, wouldn't it, if you could ever get people to look back over their shoulder long enough to tell you,
Absolutely.
or as they leave. And people leave for all, change their address and their state
Right.
for all kinds of reasons, but that would seem to be a really important and sweet spot to.
Right.
drill
What I
down.
did not see in the report was if there was a line drawn between out-of-state students who may have come into Georgia for their education and then left to go back to their home states. I did not see that actually outlined in the study. So that may actually play a role in why we lose so many healthcare graduates.
And we can talk about this later because I've had more than my share of the time. But AHEC, whether how that's going, because that's a real effort that's been underway for some time.
I think Senator
Thanks.
Jackson has one question, and then
I'm going to lay this microphone down. Thank you so much.
Larry, you have one too? Yeah. Okay. Yeah, we're going to try to stay on schedule here. With the number of people that we have, we've allotted up roughly 30 minutes for each presentation. So I'm going to let Senator Jackson and then Senator Walker, and then we'll move on to the next presentation.
Thank you, Mr. Chairman. Thank you for this really comprehensive presentation. Just briefly, in our packet, you have a map here about mental health access, but you didn't really speak to that. And so I'm curious, can you talk about our workforce needs in rural areas as it relates to mental health?
I'm going to pass the torch back to Beth. And yes, for sake of time, I didn't address all of those maps that we had in there, but there is some additional information. So, Beth, maybe you just want to come up here?
It's all green, that's why I'm like, I don't know.
It is. That's and it's very in your face as far as the green too. So.
Yes, you can definitely see the need in the state.
And I know this is a very complex question here with the mental health issues we're facing, and I hate to say it, but as briefly as you can address this issue right now, we have others that need to present, and we're already a little bit behind
Okay.
schedule, so I got to keep this train on the tracks here.
Okay. Well, as you can see in the state, presently 94.97% of the state is in a mental health HIPSA. So we are very underserved as far as mental health providers. So that's the reason we're trying to press with the National Health Service Corps and with our state loan repayment program for recruitment and retention of these providers because we are in such a need for healthcare providers.
Thank you. Senator Walker.
Thank you, Mr. Chairman, and thank you, Director Ham, for all the good work you do and the real good presentation you've made. You touch a lot of areas. I think we would all agree that access to health care is a key determining factor in economic development in any part of our state, in addition to the well-being of the citizens and the quality of life. But the economic development, if you don't have access to health care, it's hard for me to see how you're going to be able to attract industry. I think the number one issue driving economic development, in my mind, is quality education system. I think that's where some areas have a competitive advantage over others. And then I think number two is health care. And you could argue one over the other. But and touching on the CON issue, that's my biggest concern with eliminating CON. I think there's room for improvements and streamlining and modifications. But these rural hospitals, if we were to lose more rural hospitals, I think we would see a further decline in those areas as far as population and economic development. And that's my biggest concern, is that we don't go too far with that and impact that. The J-1 visa waiver program, I have had a number of calls over the last really just couple years about physicians coming from other countries that can't get licensed to practice in Georgia. Is this a composite medical board issue? Do you have any idea why that would be the case if we do have this program?
I would say, would be with the composite medical board, because when we accept the applications, they have to provide their license to practice in Georgia. I mean, that's part of it, or either where they have applied for a license.
I've had a number of
Yes.
calls about that, and I'll try to dig into that a little bit further.
And I was just going to say, not to say it's a problem with the medical board, but that would be a question we would need to pose to them, and certainly happy to make that outreach and kind of get a little bit of clarification on what those requirements would be.
I'm gonna have that opportunity later, and
Okay.
I'm sure I've got a study committee on licensing going on. But thank you. What is the average, do you know the average amount of the rural hospital stabilization grants? It didn't look like a ton of money to me when you divide it by 35 hospitals, and looked like a lot of
Right.
work for not a big grant.
Definitely, and as I mentioned in the early, I will agree it's a lot of work, but in the early years, the funding fluctuated. It had originally started at $750 per hospital, so $750,000 awarded per hospital, and then we had a couple of years where it dipped down to $250, or another year was $300,000. So we recognized when we dipped down to those numbers that they were not able to be as effective as they were when they were in the higher range. So on average, I'm not good at math, but 45 divided by 36, I think, hospitals we said, would be what the average is. But we're trying to stay in that sweet spot range of about 750, 800,000 now. So
I would
again,
think you would have to be there or higher to make it worth
absolutely.
doing. I mean, 300,000 for a hospital is nothing, really.
Right.
We have seen some impressive projects come out
We-
of the money that's been
Definitely.
allocated.
They are very appreciative, the hospitals are very appreciative of the funding. They recognize that there are so many things they would have not been able to do had it not been that funding. And a lot of it speaks to the employee satisfaction above and beyond just recruitment and retention bonuses or efforts directly related to recruitment and retention in workforce, but also some of those improvements, upgraded equipment, those kind of things that have certainly increased employee satisfaction and have been beneficial, hugely beneficial for attracting their residents back into their hospitals for their care.
I keep hearing about a renewed interest in the nursing field, which is encouraging. A lot of new students applying and wanting to get into it, despite the COVID situation and everything. But the bottleneck seems to be the shortage of instructors. I hear that over and over and over. What can we do to address that?
Absolutely, and I am not sure I would be the most appropriate person to address that, but it's definitely something that we see. What we talk about more with the rural hospitals is preceptors inside the hospital for the students, but there are some incentive programs for nursing staff to be auxiliary instructors or adjunct instructors for the schools, but I'm probably not the best to address that particular question.
Just very quickly, the commission that wrote that report had some pretty good in-depth recommendations for the barriers for educational system. So I would urge y'all to look into that. That's kind of out of our purview.
The Governor's Commission?
Yeah.
Okay.
I can get that report to Bernita.
I would appreciate that. Thank you.
Thank you.
I'm sorry,
One more?
Chairman.
Yes, sir.
So AHEC, I was disappointed. I worked with Miss Juliana on trying to identify where our nurses are, our licensed nurses, where they live. And I would have thought that was a basic thing we would have had easy access to. And AHEC did not have it, and apparently it wasn't a requirement when they renewed got their license. I think we passed legislation to address that. Is that right? But I'd like to learn more about AHEC and what they're doing and their, how much how much it costs the state for AHEC, and I would hope they would have maybe some suggestions on these nursing instructors. And then one real quick, On the percentage of healthcare graduates, 58% is your statistic. I was recently at a public university that has a medical school, and for doctors, their in-state percentage was 40%, and they thought that was very good. I thought it was not so good. I think we need to figure out why we are investing the kind of dollars in these public institutions to train a doctor, which is extremely expensive, and not keeping them in our state. So, thank you.
Thank you. Thank y'all for that presentation. We
Thank
really
you.
appreciate it. Next, we have Zachary Taylor. And just for reference, John, I'm going to get you to keep the 30-minute timer. We didn't do it on the first one. Or Miss Bernita will keep that.
I'll
Thank you
try
for
and
coming.
catch you up on everything. I'm Dr. Zachary Taylor. I'm the District Health Director for District 2. The state is divided into 18 different health districts regarding public health. I also cover the district just west of us, west of my district, which goes from Cherokee County up through Whitfield County. Can you go to the next slide? Okay. So each county in Georgia has a public health program, and there are really two parts to that public health program. The first is the health department. The health department obviously provides clinical and preventive services and does activities related to communicable disease control. And then there's environmental health in each county also. They're responsible for installation of septic systems, restaurant inspections, tourist accommodations. They do activities related to rabies control and to now body art, which was just passed by the legislature. So I'm going to talk about two types of employees that we have. One are public health nurses. The other are environmentalists. We also have, obviously, clerical people. We hire LPNs. We have, often in our rural counties, we have APRNs that travel to different counties to provide services that are beyond the scope of care for our public health nurses. So our public health nurses are unique. They're what we call expanded role nurses. A nursing graduate who comes out of nursing school, or even a nurse who has worked in a hospital for several years, is not ready to be a public health nurse because of the expanded role that they have, which involves essentially assessing patients and providing treatment based on protocols that are developed and that they have to have training for. So we don't really have a public health nurse until she's been with us for 9 months to 1 year. And as I said, they assess and provide treatment, they make referrals, they give vaccinations, and they follow these protocols, or they contact me and I give them directions on treatment or assessment of the patient or further referral for that patient. Our primary, no, go back, I'm sorry. Our primary services involve women's health. We do a lot of activities related to women's health. That includes reproductive health services, family planning. We also provide cancer screening for breast and cervical cancers for low-income women. We do communicable disease control, as I said. That's primarily the assessment and treatment of sexually transmitted diseases, as well as tuberculosis. We provide immunizations to all ages in the population. We provide services for children's health, and that can range from hearing and dental that they require for attendance at school, or scoliosis screening that's required for certain age groups. And then some of our health departments have additional services, but The first four I listed would be the primary services provided in our rural health departments. In addition, our health departments work with our schools, we work with senior centers, jails and prisons, social services organizations, and drug treatment centers to make sure that persons in those institutions have all the services that they need that we can provide for them. Primarily, if you could take what was said in the last presentation and apply it to our needs, which are primarily staffing. That's the difficulty we face. We do have good benefits. They're the same benefits state employees enjoy. That includes medical, dental, vision, 13 holidays, paid annual and sick leave, and a 401k match program, and even a pension if you work for us long enough. But again, as was emphasized earlier, younger people aren't really concerned with those things. So attracting and hiring a younger workforce is a struggle that we have. The other struggle we have is our pay. So we start out nurses at $49,000 to $51,000. We go up to $63,000 to $66,000 for nurses who have been with us longer and who have completed all of the training that's required to become a public health nurse. I'll point out that 66,000 figure, that's generally around what a hospital would start a new nurse at, a new nurse out of nursing school. So our pay is lower than what nurses can earn in the public sector. The private sector, sorry. Next slide, please. So we have several challenges in hiring public health nurses. As I mentioned, the salary and competition with the private sector. Believe it or not, a lot of nurses and younger people like the flexibility of shift work. Now, I don't understand that particular attraction, but they like that flexibility. We obviously have set office hours, 5 days a week, so that's not as attractive to some of them. We don't have tuition reimbursement programs specific to public health. We can, in some instances, access the HRSA programs that were mentioned for tuition reimbursement to pay for their schooling. But we don't really have most of our nurses that we hire are not coming directly from school, and that's less of an issue for them. Since we are talking about rural counties, many of our nurses may live in another county than the county that they work in, so their commute may be long, and if they have an opportunity to work closer to home, they'll take it. We had a real problem when gas prices were so much higher last year, and we lost several people because of the cost of their commute. We have some part-time workers, but they don't receive any benefits. And we don't have a COLA or on an annual or routine basis. But the legislature has been very generous lately in providing increases in our pay scales. And then while we evaluate all of our employees yearly, there's no monetary value associated with that, with their evaluation. So high scores don't get anything extra out of that. I'm going to jump to the environmental health, which is a totally different group of employees, and these are persons that have to have completed a bachelor's degree from an accredited university, and they have to have a certain number of semester hours related to laboratory and science. Just as with our nurses, when we hire that person out of college, they are not ready to be an environmentalist. They have to be trained, and we have to train them to be an environmentalist. So they have to learn how to do. They don't teach people how to do on-site sewage management in schools. They have to know about soils, so they have to know this is related to the septic systems, how different soils percolate. They have to know how to inspect a restaurant. They have to know how to deal with making sure animals that are suspected of being rabid are treated to be sent to the laboratory. That requires that those persons be vaccinated against rabies. They have to know about vector control. We do some activities related around mosquitoes. They have to learn how to inspect pools and tourist accommodations, and now they have to know how to deal with the body art. They have to take the same certification that a body artist, that's a tattoo artist.
Oh, is that what it is?
Yes, sorry. They have to take this, they have to take the same classes that the body artist, quote unquote, also does. They also are heavily involved in emergency response training with what happened recently in South Georgia with the hurricane. We have teams across the state of environmentalists. If they're needed, they go to that area to help them get the businesses back online so that they can continue to provide services in their community. So if the electricity goes off, food service establishments, if they don't have backup generators, they lose a lot of food because of the loss of refrigeration. So they have to go back in and make sure they have water, appropriate refrigeration, things like that, so that they can open back up and their owners can continue to earn income and provide the food for their community. And then customer service is a big issue with this group of people because, and I'll get into this briefly, because they're also a regulatory group. So they approve or disapprove someone's application to install a septic system. Obviously, they go into restaurants, and depending on the grade they give, the restaurant is able to open and close. So no one likes regulators. So they have to learn how to deal with people who are angry or frustrated with what's going on, and how to serve those people in a manner that we should expect the public to be served by employees of our government. Next. So they have the same types of benefits. As you can see, the entry-level salary is even lower. It's about $42,000 for someone coming out of college. I don't know if you have children, family, friends who are just graduating from college, but most of them expect to make more than $42,000 a year in their first job. The national average is around $47,000. We do have a career ladder. It goes from 1, 2, 3, 4, 5. Again, it's based on their years of experience. It's about a year to go from one level to the next level, and also their ability to be certified for different, if they complete everything they need to know how to do land use or septic systems, food service, etc. And then in each county, we have a EH county manager, which is a little higher level. And oftentimes they move on to the district or to the state office, which is a little bit better job depending on where they live and what their family is doing. So next slide. So sort of the same challenges. Salary is the biggest one, I'd say, for us. These people also work in different environments. If you know, they're when it was 95, 99 degrees out, they're out there examining septic systems, which is not the most pleasant thing to do. Or they're in kitchens and other areas which are not always pleasant also. And then again, they do, they're regulators in that sense. So they often deal with unhappy people who are frustrated and they have to tell them that they have to do something additional to be approved for their systems. We don't have a tuition reimbursement program for them, and there's no increase in pay. So if one of our environmentalists goes back to school, gets a master's degree, there's no increase in pay associated with that. We also don't have benefits for part-time positions, and the same as before, there's no COLA on an annual basis and no monetary value attached to their yearly evaluation. So I do appreciate the opportunity to speak to you, and I'll be glad to answer any of your questions.
Thank you for your presentation. My question, and I may have just missed this, is there any contribution from the counties towards the salaries and so on?
I failed to mention that. So the way our public health programs are funding, there really are three sources of funding. First, they get a grant and aid from the state. So that includes both state dollars or federal dollars that are passed through the State Department of Public Health. They can also apply directly for some grants, which increase the funding. And then the county provides, the county is required by law to provide funding to the health department. Now, what they're required to provide is a small amount. Almost all of our counties provide more than that amount for the public health program. And then finally, there are fees and charges for services. So if someone comes in and applies for a permit for a septic system, there's a fee for that. If someone comes to our health department to receive services, we charge their insurance, or if they don't have insurance, we have a sliding fee scale. But I will say, no one's turned away because they can't pay. And we don't have a collection agency, so if they don't pay, we're not going to go after them for that charge.
One of the questions that I had is, you brought up nurses that get a master's degree, there is no increase in pay for them. Is that because we don't have, the positions that they're in, is a master's degree not needed, or do we not have those? Or could you explain that a little bit more as to why that is?
When I mentioned that was referring to our environmentalists.
Okay.
So not our nurses. So most of our nurses, we don't really have let's say they go and get a master's of public health. We might consider that and promoting them to the next, if they're a PHN2, they might be promoted to a PHN3, but there's not really a big ladder for increases just based on that educational component. Now, if they get a master's in nursing that allows them to be an advanced practice nurse, then obviously that's a different salary scale than just a regular RN. But as I said, we don't really have advanced practice nurses assigned to individual rural health departments. We have several in our larger metropolitan health departments, but we do have advanced practice nurses that travel to the different health departments so that they can provide some of our reproductive health services.
Thank you. Senator Jackson.
Thank you, Mr. Chairman. Thank you for your presentation. Can you tell us what is is there a shortage? How many counties are missing nurses? Or broadly speaking, do you know kind of where we are on this issue?
So right now, so for instance, for our district, and just talking about our rural counties, we have about 4 open positions. And say a county like Habersham, we have 3 nurses, public health nurses in Habersham. Some of our smaller counties, we may only have 2 public health nurses. We try to have more than 1, obviously, because if they're sick or if they're on vacation, then there's no coverage at all. But it's a constant churn. It's not just those particular openings. Next week we may have more. In fact, I know we just had a resignation in Rabun County, so we'll be that'll add to the number that we have. And the problem in our rural counties is different than the problem in our metropolitan counties. If we go to Hall County, we always have 4 or 5 openings in Hall County. But we're competing against a very large hospital system. So there's a different challenge there. Most of our nurses in our rural counties, they live in those counties or in rural counties nearby. They enjoy their work. They want to be part of their community. So we actually retain nurses in our rural counties slightly better than we do in our larger counties. Yes.
Well,
That was a question, I had the same question. Senator Jackson is there.
Any more questions? Well, thank you for your presentation
Thank you.
today, Dr. Taylor.
Appreciate the
Really appreciate it. All right, next we have Liz Atkins, Executive Director, Georgia Trauma Commission.
Jumping to you, sorry. I have some animations in there. Good morning,
Good morning.
and thank you so much, Senator Hatchett, for the invite to talk about this. And as I looked at the resolution that created the study committee and saw that you were about surgical and surgical subspecialties, trauma is a surgical disease, and so this is very germane to what we do. So we are grateful for the opportunity to have a few moments of your time. And I bring you greetings from our chairman, who's in Australia right now and is texting me with beautiful pictures at 4 a.m. So that's been fun. And you can advance. We'll get all the bullet points up there. There we go. So I just wanted to start out with giving you all a little bit more reason for why you're here and why the work that you're doing as this committee is so important. And a well-organized trauma system saves lives. It's very well documented, and this is the story of an 18-year-old. This happened not very far from where we're sitting, and this story plays out all over rural Georgia every day. But this is an 18-year-old. I know sometimes in the news we hear a lot about firearm injuries, and those things tend to attract a lot of attention, but this is really the nuts and bolts of a lot of what we see. But this was a young man just weeks away from his high school graduation, and he was out on a motorcycle and unfortunately came around a wet corner and lost it a little bit there and slid out, and the vehicle you can actually see on the bottom left there, or sort of in the middle, that truck was equipped with front and rear cameras, and that is the view right before that young boy is hit by that truck, and he couldn't do anything to avoid him because the bike was still sliding. The top picture is actually after the truck hit him. The boy is still in the road, and you can see what's headed right towards him is a big tanker. So really devastating. When EMS responded on scene, they were actually closer to a non-trauma center, but they knew based on his injuries, he was still conscious and alert, thankfully. He hadn't been head injured. They knew he needed to get to a trauma center, so they took him to what was a level 2 at that time. It's now a level 1, part of the Northeast Georgia healthcare system, which we are at today. And that young man was in the operating room within 32 minutes of arrival. He had very complex intra-abdominal and orthopedic injuries. He had multiple surgeries over the next couple months. And even though that was right before his high school graduation, you see him there months later. Not only did he survive, but he's under the arches at his orientation to his freshman year. So these are the things that we like to celebrate. This is the reason you are all here, and we thank you for bringing this attention forward. So next slide. So I have to give you a little bit of an overview just so you can kind of, for context purposes, and next slide. So what's the difference, right? What's the difference between, for example, a center that we're sitting in right now and a trauma center? And really the trauma centers deal with most of the most severe injuries. They are equipped to stabilize and transfer in the more rural trauma centers, such as the level 3 and level 4, and we'll go over that in a second. And then emergency departments more commonly treat, less serious broken bones, maybe loss of consciousness, heart attack, stroke. We hear lots about heart attack and stroke. Gastrointestinal illnesses, shortness of breath, sort of the medical things that you think of. And next slide. So in Georgia, similar to what the national norms are, we have 4 levels of trauma center. Level 1 centers provide total care, and that's really from prevention through rehabilitation. And these are what we think of, you think of an Atlanta Grady Hospital. Now, as I mentioned, Northeast Georgia Hospital. We have 5 level 1s in Georgia. They have teaching programs, and they teach medical residents, surgical residents, and they are really doing the research that drives trauma care and how we manage trauma patients. The level 2 trauma centers are very clinically similar to level 1 centers. However, they most commonly do not have the teaching component. And they typically treat both adults and children. We have 2 level 2 pediatric trauma centers. One is in Augusta, one is in Atlanta, Scottish Rite. And we have 1 level 1 pediatric center at Eggleston. Level 3 trauma centers are smaller than a level 1 or a level 2, but they can still provide prompt surgical intervention and some subspecialty care. So it's important for you to remember 1s, 2s, and 3s are surgically driven. Now, when we get down to the level 4s, which you commonly see in the rural areas and underserved areas, they really are more emergency medicine driven. So that's why the emergency medicine specialty is really critical in these areas. And most of these patients that arrive to level 4 trauma centers will be, their primary goal is to begin rapid resuscitation. We'll talk about some of the challenges associated with that, and then transfer to higher level of care. So next slide, please. So who writes the rules for all of these different levels? And you'll hear me mention this again, but the American College of Surgeons, that little gray book that you see there on the left, we're suffering through a transition now. These are the new so-called criteria that were just released and go into effect, in fact, this month. So unfortunately, the American College of Surgeons left out level 4 criteria in this iteration of their book. They recognized that that was a major shortfall, so they are going back to the drawing board. Thankfully, Dr. Kirkpatrick is very familiar with this. As an orthopedic surgeon, you know this better than anyone. They actually developed a rural committee that's actually comprised of rural trauma surgeons instead of being urban surgeons who are kind of dictating what's happening in the rural environment. So this is very encouraging to see. So we will see, currently we're using the old guidelines right now. That's what the college has recommended, but they are developing new guidelines. So we look forward to that. As well, oops, sorry, if you could back up 1 minute. On the right, we'll talk about this in a little bit too. The American College of Surgeons also has standards around what optimal trauma systems look like, and that's mostly what the Georgia Trauma Commission is really involved in. Next slide. So what's a trauma center? You see there in the middle sort of all the different roles, and as you've heard the presenters before me talk about these different positions and how hard they are to fill, and the recruitment issues and the whole reason why this study committee was assembled, right? If we don't have people to fill those positions, we don't have trauma teams. So we most commonly, if you can look at that NASCAR picture on the bottom, I think everybody understands how quick that team, they don't even talk to each other, right? They know what they're gonna do. You can see them ready before the car even pulls in. And that's what we like to think about. The well-functioning trauma team functions a lot like a NASCAR pit crew. Next slide, please. So just a brief background on our trauma system. So we've been about 41 years in the making. We always say, but who's counting? We keep chipping away at it, right? It's never perfect. Our first trauma center was designated about 42 years ago. And again, we've made significant progress, but when we talk about some of the challenges in the rural trauma care environment, we're not quite where we need to be yet. And next slide. So, not unlike we're all here right now, the Georgia Trauma Commission was created out of a study, Senate study committee, both House and Senate study committee, which was created during the 2006 legislative session. It was 5 members on the House side and 5 members on the Senate side, and they heard testimony from all over the state. from state and national trauma experts. There were 5 regional public meetings, and next slide. And you can keep, yeah, there you go, thanks. And these were some of the key findings. So our death rate at that time was 20% worse than the national average. I have some slides on this that'll show you where we are now. Only 30% of traumatic injuries were actually treated at designated trauma centers. It's not uncommon that injuries are treated at non-trauma centers, but we want to make sure that the most critical patients are going to trauma centers, and we have some information to share with you on that too. Traumatic death rates in rural Georgia were much higher than urban areas. And annually at the time, Georgia's trauma care providers, and this is the hospitals, the surgeons, and EMS, were delivering about $250 million in uncompensated trauma care. So people were fleeing the system. There was really no incentive to participate in the trauma system. Next slide. So this shows you again where we were right before this Senate study committee. And if I can show you, if you can see where I-75 is sort of the red line that goes down through the middle of the state. And you can see where you get somewhere around Macon, where we start kind of outlining the counties that traverse I-75. And a number of those counties are quite a distance from a trauma center, or were quite a distance from a trauma center at that time. And at that time, this was data compiled by Dr. Pat O'Neill, who many of you may know, who served for a while at the state. And the death rate in these areas was almost twice what the death rate was for the entire state. So unfortunately, I-75 became known as the corridor of death. And you know, many people travel through I-75, even coming through other states to go through Georgia. And so without funding, retention was a problem. So we already had an issue where we didn't have enough, and then people were leaving. Next slide, please. So this, at our first ACS visit, in a system consult visit in 2009, became coined as the islands of excellence in a sea of chaos, right? We had centers who were holding on. They were trying to do everything they could to deliver really good patient care, but there just was no good coordination between them. And next slide. So this led to the formation of the Georgia Trauma Commission. So this was SB 60 in the 07 legislative session, later becoming known as official Georgia Code 3111-100 to 103, which established a 9-member Georgia Trauma Care Network Commission. Right now, we're administratively attached to Department of Public Health. There's 3 other full-time folks plus myself, so we're a very small but mighty team of 4. And our annual budget is about 23 to 21 million. That primarily comes from the super speeder funding, as well as a small portion of the fireworks excise tax. Through that, it sounds like a lot of money, but when you got 35 trauma centers, and I'm proud to say that every single trauma center in Georgia right now is funded. If you're designated, unless you came in after the start of the fiscal year or after we submitted our budget, which I think is just 1 center, but we'll add them next year, everybody is funded. In addition, we do funding for EMS, and that is legislatively mandated for centers in EMS, where we do a portion of readiness and uncompensated care. And then we have a number of initiatives to support trauma system development. And so next slide. And so this kind of shows you where we are now in terms of the distribution on the right. And I do have the map on the left kind of depicts where the EMS regions are. So I think Nita's map showed this really well too. If you look at regions 8 and 9, and you remember her map, we have a lot of rural ground to cover down there. And particularly in Region 8 and south in Region 7, we have a lot of areas where we don't even have any hospitals. So EMS transport times are very protracted in those areas. So patients may travel a long distance in those areas to get to a trauma center. Next slide, please. And so just to highlight some of our rural care initiatives and programs, and next slide. Probably the biggest thing that we were able to accomplish this year, and it took us at least a year in planning, is that we had, and remember I showed you the slide where the American College of Surgeons is the one that sort of writes the rules for trauma centers as well as essential elements for trauma systems. We had an American College of Surgeons trauma system consult, and we added on, we asked them, we were the first state to ever do this, and they're going to use us as a template moving forward. We asked them to come look at our rural trauma system. We said, hey, we've got issues here. We don't really know how to deal with them. Can you guys send us some rural experts? And that's what they did. They sent us a team of 7 folks from across the country, primarily rural, a couple folks that were from larger city areas. And we had about 130, 140 people in attendance. It was amazing. Just like this, it would be great if we could meet more often to kind of brainstorm about some of these issues. And so that was early this year, just before or right on the beginning of the legislative session. And next slide. So I've given you the link for the full report. I think the full report has a very good overview, executive summary, as well as the full rural focused piece, and I think it's very worthwhile looking at. System-wide, there were 14 priority recommendations, 89 total overall recommendations. From the rural focus, there were 8 priority recommendations and 29 overall rural recommendations. We have the exit summary that was videotaped because we did it by Zoom. The team was there for a full 5 days. They had 3 stakeholder visits across the country, but they stayed sequestered so they could actually do our report and then give us a really nice, meaningful exit summary on the last day. And next slide, please. So I'm just going to hit the highlights of what the priority rural recommendations are because it's very germane to the work that you're doing here. And the first one was to perform a comprehensive resource needs assessment, including funding for the rural trauma system, emphasizing obviously the rural aspect of EMS and the trauma hospitals, and then a rural capacity needs assessment to identify gaps, which included, again, EMS, the trauma hospitals, and transfer capabilities. Because just because the patients make it to the hospital, now we have the conundrum of how do we get them from the rural trauma center to the tertiary care center when they need to, because our EMS colleagues are certainly not flush with staff. And then exactly what you're here for, recruitment and retention, primarily focusing on trauma providers, nursing, and EMS. And next slide, please. So, and then you can hit it again. So one of the things we wanted to understand, our group has published quite a bit on a number of things, not only access, but what does it cost? And we've published twice on the level 1 and level 2 costs. That's been out there for a while. That's pretty well known. But we never had a sight line into what does it cost to run a level 3 or a level 4 trauma center. So this was the first data in the country of its kind. This went crazy on social media when Dr. Ashley presented this at the AAST, American Association for the Surgery of Trauma, because everybody wanted to know how much it cost, so we could actually put a number on it for the first time. So the average cost for a level 3 trauma center, this is readiness. This is kind of what it costs to keep the lights on before the first patient ever comes through the door, was about $1.7 million. And the highest cost, not inconsistent with what you've heard already, is the clinical medical staff, right? Because everybody gets call pay now. Nobody's even going to come to the table to talk to you unless you have some sort of mechanism to provide them with call pay. So if we're on call, if I have an orthopedic surgeon and I say you need to be at the hospital within 30 minutes if we call you, he's gonna want call pay, he or she. And then level 4 trauma centers, that $81,000 is extremely conservative. We know it's higher than that. We just could not get the information out of them. This was really hard to get out of them. We do want to repeat this because we think we've figured out some ways to help them kind of quantify the cost of that emergency medicine coverage, because that's primarily what they're having to cover. And they reported their highest cost category was the administrative cost category. So, next slide. Primarily, I think, because they couldn't quantify that medical staff coverage from the ER. But we think we have a formula to help them with that next time. So, what are we doing about some of these things? We're really proud. We couldn't do the work that we do with a staff of 4 without partnering with many of the people even in this room. And one of the folks that we partner with is the Georgia Emergency Medical Services Association. They do a lot of education, professional and initial licensure education, so EMT, EMR classes, as well as continuing education classes. Last year, they delivered over 189,000 contact hours in education, which is a feat among itself. but knowing the gaps that we have in recruitment and retention, they were also funded to do a public service announcement, which should be airing very shortly. We just got the final approval on that. So again, I think you've already heard some of the challenges with recruitment and retention. This is a little bit of a different era. When I, looked at that, that's sort of the opening scene on the PSA is, what do you want to do with your life? You want to make a difference? Well, we have to talk about, pay and flexible scheduling and things like that. It's just not enough to say, I really want to help people anymore. We really need to make it a little bit more attractive. And I think that recruitment and retention for EMS has been a perennial challenge, right? You've already heard about environmental health. I mean, there are not many people who want to lay on their stomach in a ditch and try to intubate someone on the side of the road. And in my previous life, I was a flight nurse, so I've experienced some of that myself. And it's just hard, and you're not gonna keep them in the field for long. I'm also married into EMS, so I feel like I live, eat, sleep, and drink recruitment challenges and healthcare challenges. So next slide, please. And then the next priority recommendation was to ensure involvement and participation of the rural trauma hospitals and EMS in an inclusive statewide trauma system plan. I have to say, we had our colleagues at DPH years ago, we had a beautiful trauma system plan, but nobody knew where it was. And we didn't really look at it. We didn't regularly visit it and say, are we doing these things that we say are optimal things? So we need more than to just check a box. We need to actually write the plan the way that, and have metrics that we go back and revisit it. And when we talk about an inclusive statewide system, we tend to focus on those real critical injuries. But a lot of these rural hospitals, what's going to keep them alive are some of those minor injuries that we shouldn't necessarily bypass the center to go to a higher level of care, because those injuries can be managed at that facility, and it's actually good business for them to keep those patients where they need to be and not far away from their loved ones. So next slide. And then the next two recommendations: standardized trauma care in rural Georgia utilizing educational programs, and increase rural emergency medicine providers and resources to provide capability to manage traumatically injured patients. One of the biggest educational programs out there for trauma care for providers is advanced trauma life support. Very hard to take that course on the road. Senator Kirkpatrick, you know about this. This course was actually by an orthopedic surgeon who was in a horrible accident, and found that his experience was that people in rural areas don't understand how to save lives. Trauma care is different than cardiac care. It's different than stroke care. And sadly, it's not very cookbook, because traumatic injuries don't follow any specific path. So next slide, please. So one of the things we like to do at the commission is, when we can't figure something out, we phone a friend. So we looked at some other states who had similar geographic distributions such as ours, and pockets where there were maybe no rural trauma centers. And how do you tap into that? How do you make sure it's bad enough these people can't keep the lights on and take care of the patients they have? How do we tell them, oh, by the way, you also have to evaluate the care you're providing. You have to figure out where the opportunities are. So we looked at Pennsylvania. We actually looked at Pennsylvania and Texas, but Pennsylvania was actually able to do this for us. So they sent a team. They have a very structured program for level 4 centers, and they have requirements that are above and beyond what the American College sets out. So they came and they visited 5 of our level 4 centers. They sent 2 teams of 3 reviewers each, and the best part was they had emergency medicine physicians. So these weren't urban surgeons coming in telling the rural providers how to do it. These folks had experience in the rural areas themselves. So the reason we did this, we wanted them to evaluate what our level 4 readiness to take care of injured patients really, tell us the down and dirty. We want to know all of it. And then we wanted them to share, we know you guys have some really high functioning level 4s. Could you share those best practices? And then we wanted them to come to the commission meeting and present their aggregate findings. And next slide, please. Some of these, honestly, were a little bit hard to hear. Not unlike what you've heard earlier, the community commitment was incredible. These folks are very engaged with what they do in their communities, and they want to do a good job. They simply don't have the resources to do it. And despite their limited resources, many of them were actively engaged in injury prevention and outreach, which was some of the things we struggle with the level 1s and the level 2s who are much better resourced. Many of them had very adequate facilities, lovely facilities, as a matter of fact. They had great access to equipment and strong hospital leadership support. They wanted to do the right thing. Unfortunately, the trauma program managers might have also been the emergency department manager and the stroke coordinator and the quality improvement person and whatever else. They were wearing too many hats to be able to do the role that they needed to do. And the same thing with the medical director. So really just a lack of time and really financial support for education. So we heard this loud and clear at the commission level, and in fact, we've doubled the amount of money, readiness funds. That it's still not enough, and we know we need to measure it, as I mentioned. We also didn't really have, one of the things that Pennsylvania does really well is they have a really good formalized mentorship program, so they can pair some of the rural centers up with some of their colleagues at the level 1s and 2s and provide that support. And that helps even with the patient throughput and transfer process, right? If you know the other person that you're speaking to on the other side of the phone, it makes it much better. And then nobody, and I mean almost nobody, had a standardized or structured process improvement plan. They just don't have time to look into the care. It's hard, right? Next slide. And so this was sort of our own homemade course, if you will, that we're really proud of. One of our commission members, Courtney Terwilliger, led the way. And if you want to talk about engagement, here it is right here. And that the bigger picture there on the left, Alicia Register, you probably can't see it there, is about 9.5 months pregnant. I think she delivered the week after that picture was taken, but that was our inaugural March Pause course. Now, March Pause is a military mnemonic, stands for massive hemorrhage, airway, respiration, circulation, head injury, hypothermia, pain, antibiotics, wounds, and splinting. And it's basically a down and dirty, here's what we do when the patient arrives, here's the things we have to do. We initially called it 5 things to save a life, and that wasn't sexy enough, I guess. So we decided we'd go with March Pause, since that was the mnemonic that we were teaching. Because, as you know, Senator Richter, they don't have time to sit for a 2-day ATLS class, right? So we got to get in there for 2 to 4 hours and just come back year after year. So this is kind of how this was designed, and this was our pilot course, which happened just a couple months ago at the State Office of Rural Health. So we're so happy to partner with our colleagues. I think the partnerships in Georgia are working. That's something loud and clear to hear today. And then on the top right, that's Greg Patterson. He's the trauma surgeon and medical director at Archibald, who's one of our level 3 trauma centers down there on the border in Thomasville. And then Courtney Terwilliger down the bottom. And next slide. So 2 more of the rural focus priority recommendations: improve scene response times by bolstering existing mutual aid agreements and addressing staffing shortages. So here we go again, right? You're seeing, I'm certainly adding fuel to your fire from this ACS report. But I think the scene time piece is not necessarily when we're talking about what time EMS gets the call to what time they arrive on scene, but again, what we found that most of our challenge is getting the patients out of the rural hospital to the level 1 and level 2 care environment. And then developing a process, this is something we're really excited to start looking at now. Develop a process for what's known as rescue stops and accelerated transfer. So what we mean by rescue stops, and we're working with the folks, our neighbors in Alabama, who do this really well, where instead of EMS coming, bringing you, similar to the scenario that I started with, that patient to a rural hospital, and then, okay, we leave, call us when you need us to transfer. No, they stay there with the patient. The patient has auto acceptance to a higher level of care. The patient's stabilized, starting blood, fluids, whatever, and then we're on the road. We're not gonna, because then by the time I leave, I got to come back. Yeah, exactly. And we may be on another call. Some of the contracts require that a 911 ambulance always stay available, so they can't do an inter-facility. So this really helps put the patient at the center. Next slide, please. And then next recommendation, provide education and collaboration for rural facilities to achieve proficiency regarding data entry and validity. Again, this becomes so low on the priority list when you're just trying to take care of patients every day, right? They don't have the expertise to do this. And then provide rural trauma program managers process improvement training along with mentorship and support from other facilities. And next slide. So we have one of our programs within the Georgia Trauma Commission is what we call the Georgia Quality Improvement Program, or GQIP as we refer to it. And so that group consists of the trauma program managers and the trauma medical directors from all of the trauma centers across the state. They meet in person twice annually. We just reinstituted what we're calling the closed peer review meetings. And this was almost like an act of God to sort of get this done. We had to work with the AG's office to get a special attorney who specializes in peer review, which I know you're familiar with as well, to write a resolution to get us to be able to do this. And so what this does for the rural centers where they might not have another physician who can review care and say, hey, you know, did we do the best we could? What opportunities exist here? This gives them the benefit of having the 34 other centers in the state be able to say, hey, let's take a look at this. And I got to admit, we were a little nervous when we did this because we weren't sure how this would be received, but it was amazing. There was so much great discussion. We had three really good meaty cases that we talked about here. And I was writing notes like crazy on some of the opportunities that we at the commission could potentially fund. And some of it is that I didn't realize that, you know, we preach that we want them to initiate resuscitation and do it correctly. However, it is cost prohibitive for rural centers to get platelets because they're so expensive. They don't use them, they're throwing them away. So we're now looking at other states that have programs where they can rotate blood supplies so that maybe we can, and maybe we can get more blood. There's actually up in this area, our colleagues at Northeast Georgia have led a pre-hospital blood, actually plasma program, and it would be great to do something like that throughout the state. Yes, sir.
And I want the
Oh,
committee
please.
to have time to ask questions. So
Yeah.
does anybody have any questions right now? Yes. Senator
Thank you.
Patrick.
You're definitely preaching to the choir here, because I live, eat, breathe, and sleep this stuff too. I'm married to an ER doc, so that makes it even worse. I have to give a shout out to former Senator Cecil Staton, who really started this ball rolling based on a personal trauma experience that he had. And the concept and the goal was the golden hour of trauma, to have everybody be within an hour of a trauma center, because that can determine living or dying. And so I congratulate you on what you've done so far. It sounds like you've got a lot of really exciting things going on. I'm particularly interested in the PAUSE program. That just seems like a great stopgap for hospitals that don't have the resources. And you talked about mentorship, so I'm hoping that you guys have great partnerships with the various hospital associations, the GHA and the GACH and whoever else there is to work with, because they really are at the grassroots in terms of getting the word out. So my question is that how you're operating? Is that how you're
Yes.
communicating?
So it's almost like you teed me up for that question, because we just participated with GHA's rural committee. They invited us to come at their meeting in St. Simons to talk with that group about what, similar to what Nita showed, you know, the feedback. We said, like, we need to hear it unfiltered, you know, tell us what it is you need to do and how can we help you. We know not every center is going to be a trauma center, but how do we get you the things you need to take care of injured patients? How can we have this inclusive system? So yes, we're partnered with the right. I think we could always have more partnerships, but I think we have the right people at the table.
Senator Jackson.
Thank you so much for the work that you do. So full disclosure, I worked as an EMT for a very brief period of time because it's stressful. And I'd rather care for souls than bodies. But nonetheless, I am curious, are there, I mean, we know we have an EMT shortage across the state. Do we have good recruitment mechanisms in the high schools to move young people into that field? And then thinking specifically about rural needs, are our EMTs being trained at a higher level? Do they have more equipment, given the long distance? I mean, I worked in DeKalb. It's 5 minutes to the hospital, right? But I would need a lot more equipment, I feel like, if I'm in a 30-minute or an hour-long transportation situation. So, yeah, is there additional training? Are they having better equipment? What's happening there? And then do we have some good programs for recruitment at the high school levels in our rural areas to train up EMTs?
Excellent questions. And I think you have a speaker later today, Chad Black from GEMSA, who is
Yes.
probably going to address some of
He
those
can-
things.
He can address
One
that,
of the
yeah.
things that I did want to bring up, though, is at the opening session at the last legislative session, I was so impressed by the work of GDAC and the healthcare workforce dashboards that they developed, but I was really disappointed to not see pre-hospital on there. So I just checked last night in preparation for this presentation because the DPH Office of EMS and Trauma is working with GDAC to get EMS data up on that dashboard, because one of the things that they think they might be able to do, we know we lose a lot of EMS personnel, not necessarily to the Georgia General Assembly like we do, but but to nursing, because they can get paid for, more money, right? So we think that between the nursing database, there might be a way to look at what is the migration path out of EMS to nursing, so we can figure out, that can help inform some of your solutions potentially. But I do think you'll hear from Chad later today on some of the recruitment strategies, because it is important. But to the transportation piece, that is so critical, because yes, they will spend a lot longer in ambulances. One of the major challenges is getting some of the clinical experience, because, there's only so many clinical sites that you can get experiences. One of the life-saving things that pre-hospital folks can do is intubate someone, provide, and take over mechanical respiration. But if there's no sites for them to be able to do that, and the opportunity doesn't present itself but a couple times a year, how proficient can you really be at that?
I'm going to put you on the spot a little bit. And it was when the map with the trauma centers and where they're located in the state, and then we obviously went into the EMS piece of this. In your opinion, do we need to focus resources more on EMS and quicker transportation, or do we need to focus on putting trauma centers in new locations?
I would say we do have a trauma center recruitment opportunity, but I think we need to figure out how to get the patients where they need to go in the most rapid manner. I was surprised in preparation for that ACS system consult that we had. One of the things we had to do is inventory where the air service providers reside. And I was shocked to know that we have 29 air bases throughout Georgia. And South Georgia has a very good presence of air medical transport. Somehow, and I know because I was in the business for several years, and even sitting in my helicopter in Atlanta, at Children's Healthcare of Atlanta, the pilots would say, well, I can get you down there to the sick kid, but I can't get you back because we have weather coming in, there's foggy conditions down there, there's all kinds of phenomena why you can't fly in South Georgia. Why can't we leverage some of those air bases? I've had conversations with them, they're interested in this, they just don't, we have to have the right conversations and figure out how we do this. Or even just try a pilot, that's one of the things that we talked about. Let's maybe pilot it, maybe it's, it can be successful. Or how do we deploy, again, from the big academic centers, could we send somebody out to backfill your zone if you can't leave your county uncovered? Many of these counties, the sickest patient is probably the one in the ER, not the call that you won't have for the next 48 hours, right? Mm-hmm.
Thank you. Thank you for that.
Thanks for your excellent presentation, and I know there's more to share if time allowed, and look forward to. We're very fortunate to have you in that position, in my opinion, and it's just been excellent. Number one, and this is right on following your question. What about investing in more medevac helicopters? Would that be a good thing to do with some surplus state funds?
I think the air medical community would love to hear you say that, but I'm not sure that more is always better. As you guys are probably hearing from the discussion here, sometimes there's no amount of money you can throw at something that's going to fix the problem, because again, sometimes in the areas where we need them the most, they simply can't fly. I think what we need is the expertise of the people who are on them to somehow, deploy them to the areas where they're needed to, where they may be able to transport them by truck, and can't necessarily. When I was grounded for weather, I got on a truck and we would drive wherever we needed to drive to get the sick kid.
I'm under the impression, and clear this up for me, that we are woefully short of trauma centers compared to our adjoining states. I heard, haven't fact-checked it, that the city of Charleston has 4 level 1 trauma centers. And you may or may not know that, but there are dozens more trauma centers in other states that are similarly populated.
Can you go back up?
I just think we need to be really in the real world on this.
Back again. Back before. So, I put this here because
that's my district.
This made, obviously this made headlines nationally, really.
Yeah, exactly.
And it underscored what a scarce resource it is. But if you go to the next slide, we've had centers leaving the system for a long time. Now, when Dr. Ashley and I were asked, to comment on the closure of Atlanta Medical Center, it tended to be more, or thought of as more of an Atlanta-centric event, but what people didn't understand was that created a backlog of patients who were waiting to get out of their rural center and get to definitive care, right? Because definitive care centers are so crowded right now. So really, definitive care centers need to be at the table for some of the discussions, because if the patients can't get out, again, this is where the rural health providers, what a daunting task to have, a patient you can't care for.
So aren't we relative to population and geography? How do we compare with our southern states around us?
It's a great question. And even some states have added level 5 trauma centers.
Right. And so what's the answer?
I'm not sure. Because we are growing. We have designated in the past couple years more centers than we ever have, and we have at least a half a dozen in process right now. So we're really encouraged by that. The other piece is, I think we have to balance over proliferation and make sure that, again, we're delivering that high quality care. So I think we're positioned well for
But could you
growth.
get the numbers for us, the states around us? Because I think we need to take a look at some stark realities about what we've been hammering on this trauma system, and you brought a new whole level of put the spotlight on these level 4s, which is what we need to really pay attention to, in terms of addressing the rural needs. But getting those numbers for us would be very helpful, and you're really a resource. Thank
Absolutely.
you.
Happy
Thank
to.
you.
Thank you. Thank you, sir.
All right, next we have Amy Reeves with the Georgia Board of Healthcare Workforce. And what I'd like to do is we have Amy Reeves now, then Jimmy Lewis, and then we're going to take a quick break for lunch.
I know it's not healthy to sit too long.
And I was thinking about a 30-minute break for lunch. What do you think? Oh. And then, yeah. So, thank you very much. That's right. At least we're in a hospital if anybody needs it.
That's right. Good morning. I think I'll be the last one to say good morning, right?
That's right.
Mr. Chairman, members of the committee, thank you for allowing us to be with you today. It's a real privilege. My name is Sheila Humberstone. I'm with Stonebridge Consulting, and I'm here today with Amy Reeves, who wears a multitude of hats, and I'll let her tell you her story. But my relationship with Amy started because she is the Legislative and Reimbursement Chair for GAPA, the Georgia Association of Physician Assistants, and so we're here to talk to you about healthcare workforce from the PA perspective. So I'm going to turn it over to Amy.
Hi, everyone. So, thank you for having us. I just wanted to tell you a little bit about being a PA and like what it takes to be a PA. So I did 4 years of undergrad. I actually did it in nursing, and then I worked for 4 years as a nurse and then went to PA school. I looked at both options of nurse practitioner and PA, and for me it was just the PA school was what I wanted to do. And then I've been working as a PA since 2006, whenever I graduated and passed board. So you have to graduate from a graduate program, and before you get in, you have to have at least 2,000 hours, clinical hours, and then you also you do rotation, so it's basically like you're on the same rotations as medical students. Like it's required, to be on the rotations and get asked questions and reports and all that stuff. So it's 2 years, at least 2 years of PA school, and then after graduation you take boards, and then you have to recertify every 10 years, and you have to keep up your continuing medical education every 2 years, which is 100 hours. 50 of those are Category 1, which are usually from conference hours and stuff. We work as part of we work with a supervising physician, and as part of a healthcare team, we can have our own patients. I've worked in many different roles. I've worked in the NICU and been on like high-risk deliveries. I've worked in pediatric pulmonology, where that is inpatient and outpatient. I've done pediatric ENT, which can be as easy as like ear tubes in clinic and tonsils and adenoid follow-ups to tracheostomies on NICU babies or, children who have maybe had some sort of accident. And now I work in general pediatrics, and I love it. I love every second of being a PA. Like, it's a wonderful career. I get to see all the patients. I get to be a part of a healthcare team where I'm valued, and I enjoy it so much. So as far as, I just wanted to kind of go over like the report from the 2020 Board of Healthcare Workforce. So I do sit on that board, but I'm not representing them today. I'm just kind of speaking of it. So the PAs partner with supervising physicians to practice medicine. Supervising physicians can delegate medical duties to PAs. PAs perform a vital service to rural and underserved areas of Georgia where there is a shortage of practicing physicians. In doing so, PAs increase the quality and quantity of medical services in the state. So I've heard this multiple times, like, especially whenever I worked at CHOA, there would be, the physicians would be scrubbed into the operating room doing sometimes 4-hour cases, if it's a cochlear implant or, whatever that surgery entailed, neck mass dissections. And we would be on the floor, seeing the patient, evaluating patients and reporting back to them. So they're really like, we couldn't see all these patients without you guys. So they're very appreciative. We have, as far as the last report we had, which was 2020 data, we have 4,484 PAs currently licensed and working in Georgia. So at our one of our last meetings with the Healthcare Workforce Board, we talked about why we only had 248 PAs that were newly licensed in the state of Georgia in the 2019 to 2020 cycle. And we're actually working on getting a survey to figure out more of why we are not getting these PAs to stay in Georgia. It's going to be modeled very similar to like medical students, and why would you choose? Did you is there a significant other in another state? Whatever those questions are, to try to figure out a little bit more. So we are working on that with goals for the December 2023 graduates. So we are working on a survey to try to help us understand like why do we have 8 PA schools and only 248 of those? And that also counts people that move to Georgia and those are newly licensed. So that's not only just the graduates, but that's also,
For me, that was a stunning statistic to think that we have 8 PA schools and 250-ish people that came in, and that's not just the new grads, like Amy said, that's new grads as well as folks that might be matriculating to Georgia from other states. So it did. I mean, that's a piece of it, but healthcare, occupations obviously didn't close, and there's if only an increased need despite what's going on with any particular infectious disease at the time.
I think Senator Jackson was asking.
Yeah, I was asking how many students are they graduating? So like what percentage does 258 equal? Are we talking about 10% stay, 20% stay? What's the
So
percentage?
each PA school has a cohort group of about 50 to 60. 60 is usually the maximum, and we have 8 PA schools currently, with other schools that are in their pre-PA planning process. 2 more are on the horizon. So
We can do better.
we can always do better. So, and so sorry, I got. And so one of the things that we think that PAs, and we've seen numerous workforce reports over the past couple of years, like Senate committee reports and workforce commission reports, where they say like you have to utilize your folks at the top of their level, at the top of their training level. Like we have to get them out there working, and like we are trying to get the HB 557 addressed it, where we were trying to get some Schedule 2s where we would be able to write for that when it's necessary. Like we obviously practice medicine on our supervising physician, so like the people who need it the most, like there are PAs in rural Georgia where there is not a physician in the emergency room. Like it's not an option for them to sign a prescription. So they are having to admit patients for pain management, where otherwise they'd be able to send them home with a prescription that, and there's other instances too, and of course we would follow the PDMP, the Prescription Drug Monitoring Program. It always goes with your supervising physician. So like on pediatrics, I don't really need hydrocodone. There's not really patients. If a patient of mine in general pediatrics needs that much pain control, they're getting evaluated in an emergency room setting. It is an issue for where I practice. We do have some ADHD patients, and I've seen numerous patients that need their medications refilled. And these are psychologist-tested ADHD patients. These are not, I think I have ADHD, I want to trial it or whatever. So these are definitely issues that affect us, where it's like, in 40-something other states, if I was practicing and seeing my patients, I'd be able to prescribe that. But for right now, and my doctor's out on maternity leave, so I'm relying on a locums to help me. So I just send her what the prescription I need and what the patient's name is. So it does create more of a workload for that. But we hear this time and time again, especially in in the rural places specifically, where there is the doctor may not be in the office that day, or I hear it from patients who are in oncology that they can't get their pain medicine refilled. So it's definitely an issue in Metro Atlanta. I know whenever I worked in a hospital, this was whenever we were very full and on diversion, and my doctors were scrubbed into the operating room, so they couldn't sign a prescription. And literally they were like, you are backing up at us admitting patients to the ER because you will not send this patient home. And I'm like, well, I can't send them home. They don't have their pain medicine prescription, So it's just the backlog of how, how it's not just one thing that it affects. It's multiple things that it puts into play. So anyways, I don't think I have any other comments. If you guys have any questions.
The only thing I will say is, not to bring up a more challenging study committee, but the CON committee that met last week, there was a cardiologist who said something I thought really wise. And I'm going to roughly quote him. It's a rough quote, so I'm on camera. I'm not quoting him directly, but he said, that he is losing recruits right out of college, right out of their training, because quality people require quality opportunity. We lose applicants to states where there is greater opportunity. And I think that's sort of the piece of it, is how do we make Georgia attractive for those PA students to want to stay and work? And so certainly part of that is making sure that we're looking at our rules and regulations to make sure that if they're afforded the opportunity to practice in a certain way in 48 other states, then that probably warrants a significant conversation. We know Georgia's not going to be out leading the charge and out in front on stuff, but when 48 other states do something, there's certainly an argument. And you guys heard that, and I think there was only one no vote on the Senate side this past session on that bill. So we really appreciate your work and your effort on that. I think the other thing, and Amy could probably address the multitude of emails that we got, particularly in and around December of last year, but it happens whenever we have a cohort of students that graduate, that the challenges of getting licensed and then getting their job description approved, because as Amy said, and I'm going to say this with no disrespect to the PAs or the physicians, but I like to think simply and try to distill things. A PA works for a physician, right? They're in a collaborative relationship. So the PA is licensed by the Composite Medical Board. So by virtue of having a license, that deems you to have met the minimum qualifications and be ready to practice, whether it's law or, road building or whatnot. Once you've got a license, that sort of says that you've met the minimum requirements. The physician is licensed by that same Composite Medical Board. But for us to work together, for PA Humberstone to work for Dr. Reeves, we've got to go back to that Composite Medical Board and get the job description signed off at the board level, and that takes a whole lot of time. If PA Humberstone, and you'd think these job descriptions are robust and flowy. They're not. They're very simple forms. But if PA Humberstone leaves and goes to a different facility and they get another new grad who has the exact same, capabilities, the same school, they're going to do the exact same work, then we have to go back to the board and got to stop seeing patients, go back to that board in order to be able to start work. And I have 30 some odd plus desperate emails from graduates from our programs that were petrified because they were graduating in December. They had practiced, they had sat for their boards and passed their boards. Some of them had fellowships at phenomenal hospitals in Georgia lined up, but they couldn't start their fellowship because of, potentially a 2-month lag at the Composite Medical Board to get that job description and that license approved. We know we have to be licensed, that's not a question, but we've got to be creative about finding ways to expedite that process, because when I went to graduate school and I graduated with medical debt, it was nothing like medical school debt or PA school debt. The thought of not being able to start work on that first day that I have a job offer and instead have to sit for 2 months means that if I heard that from my peers, I'm probably not going to look at Georgia. I'm going to look at one of the states where I can start work and start paying those loans back fast. And I will say again, thank you for your work on the legislation this past year. It does seek to make some tweaks in that area as well. And there was some additional funding for the Composite Medical Board that no doubt will make a difference. And so we appreciate you, but Amy's the expert on how all of this works. So I guess we'll turn it over to any questions you might have.
Thank you for your insight, that information. Senator Patrick.
Yeah, my question has to do with the survey. And, we've tried to expand the requiring the information for all healthcare personnel when they renew their licenses, because we don't know what's going on out there if we don't do that. So I guess my question for you is, have you talked with the Workforce Board? Can some of that be done by rule? Does that have to have legislation?
So I don't think that's going to be in the legislation in terms of the surveying, because we're trying to, maybe I misunderstood.
I'm not talking about that. We already mandate a lot of professionals when they renew their licenses to give us the information on how many hours they work. Are they going to quit in the next 5 years? Do they take Medicaid, et cetera, et cetera, et cetera. So I'm just wondering, because we hit some roadblocks with getting that bill passed last year, if any of that can be done by rule. That's my question.
I think for medical schools, it is going to be done because it's going to be tied into funds, like not as a punishment, but as an incentive. Like you're getting funds from us, so we have to have this information because I think HB 1013 addresses it and says we have to have that information for medical schools. The PA stuff, it's not on that requirement on that list, but they're like, we've got to figure out why we can't have PAs.
And I think part of what we're trying to figure out is not just at licensure, but why is somebody not getting licensed in Georgia? So how do we figure out why PA Smith, who graduated from Emory, is never talking to the Composite Medical Board, never going through licensure because they've chosen to
Yeah,
work in South
I get that part, but
Yes,
if
ma'am.
we don't even have the information to begin with about who's even out there.
That's right.
Then you can't get to that next level.
Absolutely.
Thank you. Lady, you got a question? No, sir. Thank y'all very much for
Thank you.
bringing that to us. All right, next up, we have Jimmy Lewis, CEO of Hometown Health. And then after Mr. Lewis, we're going to take a quick lunch break. I'm thinking 30 minutes, and then we'll start back up with a Dr. Thomas Hatchett. Good morning. Thank you for being here. You've got a microphone right there as well, just so the people at
Very good. Thank you.
online can see.
My name is Jimmy Lewis. I'm CEO of Hometown Health. You might wonder who is Hometown Health, so I'll give you briefly of who Hometown Health is, and then I'll give you some information I think you'll find very factual. Hometown Health is an organization, it's a self-funded organization that was formed in about 1999 for the sole and specific purpose of doing whatever it takes to save rural hospitals from closing. We've been at it from then until now. We started with 1, we went to 2, and currently we have about 20 FTEs. And they're not FTEs, they are super specialists in that those 20 people have 400 years experience in healthcare and assorted aspects of healthcare. The function that we provide is that of a resource of many facets, and the many facets include anything non-clinical. We don't get involved in the clinical side of the house because that's a little over our pay grade, so we don't do that. Rather, what we do is we deal with all of the operational reimbursement, financial sides of what goes on. And again, the effort is to do whatever we can to prevent one of these hospitals from closing. Next slide. That's what we want to prevent. That's the first 12, and there's at least 6 more that could close on any given day, depending upon what happens with the particular operation in the hospital. We've had many occasions to talk how these things operate. We average about 4 to 6 events a year to make payroll. And when you're doing that to make payroll of $300,000 to $500,000 a pop, and you come up on Monday and can't make payroll on Thursday, that's a real problem. This is what we're trying to prevent. Next slide. We got a bumpy ride, and I want to give you some information that are the facts of what goes on in the marketplace, and then if you want to discuss them, we can do so. We've talked today about workforce shortage. The workforce shortage is beyond anything we can imagine. When we go into COVID and we've got people in the ER that are dying because we can't get enough people to staff the beds, that's a real problem. Physician shortages, whether it's be 8,000 or whatever the number, I did a Google on that and came up with 8,000. We're seriously short with respect to physicians throughout the state of Georgia, and the further you get into rural Georgia, the more pronounced it becomes. Georgia's unemployment percentage is 3.2%. That has a translation that's extremely important for us to understand, in that at 3.2%, those people that are unemployable are structurally unemployable. What that really means is they ain't going to do nothing. They can't do anything. They don't have a skill set. They don't have a mental set, and that's the real problem. That's particularly a problem in rural hospitals because if that's the case, we don't have a pool to go to draw from, and that's a real problem. Financial stress from the COVID and the pandemic. Out of the COVID, on the day of the COVID, when it was announced, we ran into a situation where we had hospitals that couldn't make payroll, and we were struggling to it. The federal government came down and gave us a lot of money. When they gave us a lot of money, that was really good for the time that it lasted, and then we found out they wanted it back. And when they wanted it back, it's hard to take back money from an operation that is so difficult to deal with. So from a financial stress standpoint, we then had, and today now have, many hospitals are operating with less than 2 days to 10 days cash. And if you're running a $20 million operation with 10 days cash, I don't have to tell you what kind of pain that is. That's a real problem. We have another item here that I'll come back to, artificial intelligence transition, and I'll talk to that in a minute. The next point to be made is inflation. Inflation at whatever it is, and then depending upon the specific item that you're dealing with, can range from 4 to 6 to 10 to 12%. That's particularly problematic when you're dealing with contracts that are fixed. If you've got fixed contracts that you don't have the opportunity to negotiate a higher rate, and inflation's going up at 10, and you can't get another 2% in the next 5 years, and you're automatically putting yourself out of business. The next one is an interesting one, and there are 10 state initiatives going on simultaneously right now that are killing the entire industry, but specifically in that of rural. And these 10 initiatives include things like the CMOs, the RFPs, the Medicaid unwinding, pathways, provider credentialing, what we were just talking about here. And for these hospitals that are already resource limited and to have to do this kind of work, we don't have the resources to do it, and we can't find the resources to do it, nor could we teach them in a timely enough fashion to make that work. I'll say the next one is an economy consuming labor. When UPS announces they're paying $21 a pop and Walmart's taking that same situation, they're consuming everything that we've got to provide care with. The next subject is payer mix, and payer mix is how we get paid, Medicare, Medicaid, self-pay, commercial and such. It's kind of interesting to see that we have gone from a Medicare to a Medicare Advantage population, and that Medicare Advantage population, one could make the case that the federal government is using that to cut rates. And what is happening is in the rural communities, we'll find that those people will get posted at the front door of Walmart so they can make sure that they take all of the new people coming in and convert them to Medicare Advantage from Medicare, and that's really a problem on the particular payer mix that we're dealing with. You may or may not hear about this next one. It's the 340B. The 340B is a drug program. It's designed to help rural hospitals, and it does a very good job, but there's a tremendous amount of pressure on them to solve this problem and eliminate it, actually. And then the last one is transport issues, and we've got situations now where we have hospitals that have to pay to have the patient brought to the hospital. That's a real problem. But the one I want to mention is artificial intelligence transition, and I drive my people nuts on this. This artificial intelligence transition, if I can stress anything to you that's going to have influence over any and everything of what you do, I do, we do, and healthcare does, it's going to be artificial intelligence. This is and will transform every aspect of our lives, and it will be beyond anything we can imagine. And the reason that's so important in rural communities, we've got to learn how to do it. And with the already stretched situation that we got, learning how to do it is a real problematic situation. Next slide. Overall workforce considerations, we talked about it, aging employee base, aging general population, tight pipelines of where to get people, and employment apathy, and turnover amongst the current employment. Next slide. This is kind of an interesting one with employee turnover. This came to my attention on occasion about 10 years ago when I suddenly did an analysis on CEO turnover. CEO turnover typically runs 25 to 30% per year. Think about it. When the leadership is turning that fast and doing what it does with that kind of turn, then what happens is the ability to have continuity of strategy is zero. And that leads to major problems, both at the board level and the hospital level and those kind of things. And this is just some of the turnovers that we experience. And we've heard all the morning about training these people as they turn over. It's just virtually impossible to do so. Next slide. Okay, the problems that are exacerbated in rural, we've talked about them, and I won't get into all of this. Let's go to the next one. The next one is where we start. If we got all these problems, where are the solutions? Well, I'll give you some solutions, okay? Now, you won't like the solutions, but I'm going to give you the solutions because they're known to work, but they're challenging. The first solution is cash. It's all about cash. We can talk about every other thing that we want to talk about, but if we don't talk about cash, we don't talk about nothing. It's all about cash. We'd like to think that we clinically are solvent and all this kind of stuff, but that's not true. We are cash insolvent, and we're cash insolvent because we're turning away all sorts of services that we should be dealing with. So if we're going to deal with it, we need a couple of policy changes. The first policy changes, here goes. The first policy changes, we need to implement Medicaid expansion. I said we need to implement Medicaid expansion. And we've come a long way on that subject, but if we don't do that, we're leaving cash on the table that otherwise could go into the community and provide a growth for the service level of Medicaid and all of the health care programs that we've got. I'll leave that one alone. The next one's even more hot than this one. We got 159 counties, and with 159 counties, we got to find a way to do some kind of municipal consolidation of a sort, period. I mean, that's just what we got to do. If we don't do that, we will leave all of that money on the table that we can't get to. And that whole consolidation subject is the consolidation of counties, the consolidation of area services, the collaboration of local services, and to consolidate local area contracts such as healthcare, insurance, property. And you say, well, how in the world are you talking about all this stuff? I can tell you that last week I carried part of our team to the field, and we went to 8 hospitals, 400 miles in 2 days, and talked to all 8 boards. That's what they said. Next slide. Both of those things. All of it. Next slide.
Did you mean causality or casualty?
Probably casualty. I don't spell too good sometimes. So the next solutions are kind of interesting because these are all proven solutions. These are not what ifs. These are things that work. Telemedicine. Telemedicine is the key to what we do when it comes to the delivery of the clinical services. We got a great program over at Augusta that goes out to 13 to 15 hospitals. They have access to health care in the ER, at the patient level in the hospital, and we can keep the patient in the hospital and provide services at home and not have to carry them to the trauma center. The next one is, we need to do scope expansion and do all the research pertaining to scope expansion of services. I mean, if we are short of nurses and we got some way to expand the scope of services, this is the thing and the time now that we need to be doing that. The next one is kind of an interesting one. We can go back on the history of it, but the fact of the matter is we need to increase the hospital tax credit to $150 million for this reason. That is the cleanest, most direct infusion of cash that I've seen in my 25 years of trying to figure out how to get money into the communities. And for as much as we can do that, that puts the ownership of healthcare back into the local community through the donors that make the money work in the local level. It's working, doing really good. We just need to do more of it to make it work that much better. Replenish the fund at the State Office of Rural Health. This is an opinion. It's totally unthinkable that we would cut the State Office of Rural Health to less than $3 million after we'd got the known, proven programs that work. I mean, it's just crazy. And we're trying to figure out how to save rural hospitals, and we're cutting the way that these folks back here know how to do it, and they do it extremely well. And then the next one is kind of an interesting one as well. We need to subsidize OB. And you said, that's crazy. We don't need to do that. Well, we closed 14 OBs because we couldn't pay for them. Do you know why we couldn't pay for them? Because we were losing $1 million a year on each one of them. When we do that, we impute the poor quality of maternal care into the community by doing, and this is real simple. The reason most of those closed is because they were losing $1 million a year. If we were to subsidize 14 hospitals at $1 million apiece, that's $14 million on a $30 billion operation for a budget. Is that peanuts or what? We need to figure out how to do this because for the reason that we closed the OB units as we did it just on the numbers. But the real numbers are the loss of economic development that occurs shortly after you get rid of the OB because it wipes everything out. So what we have is a consolidation of those kind of services, and the losses just eat them alive. And then the last one is kind of interesting. We need to figure out how to create a rural stipend for physicians to keep them in rural communities, $50,000 a pop or whatever. But we say, we can't do that. Well, we can't do that, so we'll just train them and let them go to another state. And we look at the dollars and cents associated with sending them to another state. It ain't real smart. Next slide. There you have it. So, a couple of things of interest that we have learned. Again, we got 20 people. We're virtual. We don't have an office. Our office is an email address. It's been that way from day one. We don't sink a bunch of money into excess overhead whatsoever. We put our money into people and smarts and software and things that work. We operate with the most advanced software from an operational standpoint. We focus on several things, one of which is reimbursement. We have developed reimbursement programs, and we've got 700 courses, I think, 700 courses that we've developed. We have 20,000 students online across the nation, and they're dealing with reimbursement and how to file claims better and make sure you get paid for what you get for what you're operating on. We do this extensively, and it works. And we've got hospitals all over the nation that have proven the success of it. Georgia is very, very powerfully successful in doing this. And State Office of Rural Health, we work directly with them and using this kind of networking operation. The next thing we do is we capitalize on technology from our business partners. We have 70 business partners that help us fund all this project. Okay, I mean it's truly a a wild, crazy project, but it's been fairly successful. And the 70 business partners that we have started out being the fundamental business partners. And I say fundamental because that was a little bit about accounting and a little bit about painting and a little bit. We have moved far beyond that in that our business partners now are technology advanced to lead us into artificial the whole artificial intelligence program. And those 70 business partners join us twice a year, and they fund the program. But they help us twice a year, and we have 200 people that attend for the purpose of understanding what they know. Great job. We use the best technology and advanced communications. We've done over 100 webinars thus far this year, teaching these people what goes on with Medicaid and Medicare and all of those kind of things. So it works. I share y'all that with you to say, if we don't do this, we got 6 more that we can lose tomorrow. And after that, we're creating a third world nation far beyond anything we've seen. And on the OB side of the house, it's important to note that that translates into a desert below I-20 that makes South Georgia yonder city. Thank you.
Thank you. Do you have any questions? I know Senator Kirkpatrick has a couple.
Sorry, I always have.
No, you're good. This is what we're here for.
So I don't want to throw the state of Georgia under the bus on some of the things that you talked about, because a lot of these are federal programs that we have to do. The Medicaid unwinding is federal, the revalidation is federal. So we're doing the best we can in Georgia to try to deal with that. And so the federal government.
We're doing everything we can to assist in the training to help in that particular situation, but sometimes the feds aren't as cooperative as they could be.
Got it. And we also have done some things in Georgia that have been beneficial, and I have to give former Commissioner Kaylee Noggle some credit for getting the directed payment program going.
Make no mistake about it. It
and
ain't the whole thing, but it's a
reallocation of the
very
DISH
good thing.
program.
Excellent. We work directly with them, and that is clearly a very good program. Money left on the table for years for no apparent reason.
We also have a pretty robust service cancelable loan program for rural physicians already. So I just want Georgia to get some credit for some of the good things we've done, but I do have a question for you. I was not familiar with having to prepay for transports.
Yeah, we got hospitals that are doing that.
Can you dig into that a little bit more?
It's just very simple. We got transport that says if you pay us, we'll bring them.
For emergency services?
Not emergency, but transport. I'll just say transport. I qualify that.
Could you go into that a little bit more? What kind of, are we talking about like a
We're
step-down
talking about
hospital,
getting a
or-
patient to the hospital.
Okay, what's your typical patient that they would call a hospital for? Are they picking them up from their house? Are they taking them from one hospital to another hospital?
There are a lot of different scenarios that patients are transported in rural communities. I'll just leave it at that.
Well, I mean, you
One
go in
hospital
for
to another.
treatment, you go in for an emergency. An emergency is an ambulance, right?
You go in for treatment, you go in for emergency, you go in for candy bars.
Uh-huh. Well, I don't, but.
No, you don't, but
Do you have a follow-up, Senator Kirkpatrick? No. Let me ask you this. One of the solutions you mentioned was telemedicine.
yes, sir.
What can we do as a state to help with the telemedicine, or is that something that's already there that needs to be explored?
It's already
further?
there. It needs to continue to be upgraded in payments and use of system. All of this is about cash. If there ain't cash to follow it, it ain't gonna happen. And that's what we have to do with telemedicine, is continue to pump cash into it to provide users. The interesting thing, and a lot of this is controversial, what I'm telling you, but this won't be any different. Okay, so the situation with telemedicine is we have 2 users of telemedicine. We have some senior users of telemedicine, and we have some not senior users of telemedicine. And the younger people come out and played with video games, and they're all about telemedicine. We still are struggling on some occasions with older physicians who just don't want to get into telemedicine. Telemedicine is clearly, without a shadow of a doubt, proven. Remote patient monitoring is the name of the game. Period. That's just it. And there's no real reason to talk about that. You didn't ask this question, but I have a question to answer for you. Yes, that whole subject of certificate of need, with respect, I fought all sides of certificate of need. But I can tell you that the threat to certificate of need for a rural community is the loss of imaging and what goes with it when there's an imaging center put up in the next closest town, and it sucks all of the patients out of the rural communities. The other problem that goes with that also is we got a situation with insurance companies where we have an occasion where the patient gets prescribed a need, and before that patient can get home, the insurance company's called to get them to transfer their care to another unit somewhere out of the local community. That's what would happen. I mean, we could have situations where we could suck up rural hospitals in a heartbeat like that. Yes, sir.
One thing that you mentioned that I had not heard is that the CEO turnover is 30% per year in Georgia. Did you say 30%?
Depends upon the year. It's ranged from 20 to 31 or 2. You can find that in Becker's.
Can you go into that a little bit as to why you think that turnover is occurring, and I guess what we could do as a state to
First
help
and
assist
foremost
that?
is burnout. It's killing them. I mean, there's just insufficient backup. We do strategic plans and we do succession planning and all that kind of stuff. There is no succession plan. There ain't no backup. There's just no inventory of people coming along, and as a result, the people that are there, they just burn out. And when they burn out, it's kind of like, big tree of fire. It just falls over and that's it.
Is it something that could be addressed at the college level with programs in the state of Georgia that would prepare people to become CEOs of hospitals? Is it a hospital management course or I guess curriculum?
First of all, it's about education, but more importantly than all, that's about the money. If enough people are paid enough money to get into the program, then they will able to educate themselves and go work in the rural hospitals.
Okay.
But the problem is, you got to have people that have a literacy level that can support what's required to go into a hospital. And make no mistake, CEO work at a large hospital is work, hard work. CEO work at a small rural hospital is unimaginable, because that's the one where you got to go carry out the garbage and clean out the toilets and do all of that stuff just to be the CEO to help the nurses on the floor. You just had to have been there to see what it's like when that happens.
And then the last solution that I was going to ask about is the scope expansion. Could you go into that a little bit with the CRNAs, LPNs, RNs? What's their role in rural hospitals? How do you think that their, scope expansion can help?
Scope expansion can help by allowing certain services to do more things under their license than they currently do. Now, I'm going to give you an example. It's not the proper example, but it was an example. I grew up in a little town. I mean, Cordele. And when Cordele's a little town now, but Cordele was a little town when I grew up in it. The thing that was most interesting about expansion of services was the second best doctor in town was the doctor's brother, who was a pharmacist. And he did his own expansion of services.
Yeah.
And in a rural community, we need to look at how that works. We need to find better ways. You had a question?
Yeah.
I do have several questions. So one, I'm curious about your incentives for physicians to practice full-time in rural communities. We heard earlier that there's already an 85% retention rate. If we can get them there, then they will stay there. So why do you feel like we need to offer them additional money
We got to get them there.
to get them there?
Yeah.
So what if we had a one-time settlement fee instead of a yearly retention?
Whatever it takes
Okay.
to get cash there.
Okay, and then my other question, back to kind of scope of care, and you may not be the best person to answer this, but are there rules and regulations that are preventing people from practicing at the top of their scope already? So we heard that previously about PAs. In my experience as an EMT, there were rules and regulations that prevented me from operating at the top level. Have we evaluated that to make sure that people within their already training, so instead of expanding scope of care, they're already being trained to do certain things, but our rules and regulations are preventing them from operating at the very top?
I'm not the proper person to answer that.
That's what I figured.
Absolutely, there are rules and regulations in Georgia. That's why 48 states allow advanced nurses to practice at their full training. Georgia's one of two that doesn't. And we've fought this battle every year since I've been in the Senate, 8 years. And it's, MAG fights us on it every time.
My sense is that it's not just advanced practice nurses, but that it's across the field, that we have a number of allied services or a number of places where people are not working at the top of their scope, is my sense.
I'll mention this very quickly in deference to the chairman over here, and that is we've had many, many conversations about what goes on in rural because he's rural. Now, the important part about that is the fact that he is in communication with rural on a daily basis. Y'all need to be in communication with rural on a daily basis just to see what it's about, if you hadn't, and see what goes on there. Because he and I have many conversations about what's going on in the rural community, and some of them are unthinkable, but they're real. And you as legislators are there to make the changes or adhere to the changes or whatever. But you got to be there and you got to hear it. You got to listen to it.
I just wish everybody in this healthcare field understood what you understand about Medicaid expansion. It's all about money. It is money. It is cash dollars. It is money.
It's all about the
And
money.
you used to oppose it, and you changed your mind, and now you're outspoken about it. And we have the Hospital Association in Alabama that loudly proclaimed the need for Medicaid expansion.
It's all about the cash.
That's what it is. It's money.
all about cash.
It's money, and it's the jobs and the infrastructure funding that money will do.
You know what the greatest leverage, in my opinion, the greatest leverage to deal with the redirection of money is? The CMO contract. The state CMO contract. If we figured out how to properly negotiate those contracts on behalf of the state and follow the money, there it is.
Well, Mr. Lewis, we appreciate you being
Thank
here.
you for
and, you know,
sorry I went a little long.
While we think we may have all the answers to all the problems in the state, this is you did bring us some good solutions for rural health care. And, you know, I think as we continue through this process, we're going to see that the needs of rural health care versus the needs of urban health care are very different. And people fighting for, well, people fighting for the, hang on a second, please. People fighting for the best of their patients, they have different interests in rural versus urban areas. We're here for rural, and I really appreciate you coming today. Thank you very much. So we're going to take a quick break. We have lunch for everyone in the adjoining room. Let's say it's 11:58 now. Let's start back at 12:30 with Dr. Hatchett. And y'all, Miss Bernita's telling me to direct y'all through the double doors, please. Thank y'all. All right, all the members are back. We're going to get started. Next up, we have Dr. Hatchett.
Yeah, it's familiar.
Yeah.
My name is Tommy Hatchett. I'm an OB/GYN. I've practiced here for 30 years, and my goal today is to try not to embarrass my son. Today I wanted to just kind of tell a story of the Habersham County experience, what we've gone through with our rural hospital and the challenges that we faced over the last 70 years, basically, and to share some of the things that we did well, some of the things we didn't do so well, and then to talk about physician recruitment. I had the honor of working on the Georgia Board for Physician Workforce for a dozen years with Senator Kirkpatrick for a while, and we did our best to make a difference there, and so that's what we're doing today. So this hospital was prior to, in the late 40s and early 50s, if I'm an OB/GYN, so some of my comments may be in that direction, but if you were going to have a baby in Habersham County and not have it at home, you would have it at the Charm House, which is a beautiful antebellum mansion in Clarksville up here. They still have a room upstairs with a glass window, and that was the nursery. But in 1953, this hospital was built, and there were 53 beds, and that's basically what it's been since then. In 1991, there was a large addition that was undertaken, and it was at this time that I actually got to see this facility. It was still under construction. I was a third-year resident, and that's when I decided to come to this area. I attended the state medical fair in Atlanta, and decided to come to Habersham County to raise our kids, and we decided why not come to a place that some people like to vacation and live. So that happened in 1991. Then in 2008, we had another large addition, and that's the facility that you're in currently. It was a $36 million addition and refinancing of the county bonds. And then just earlier this year, the facility was purchased. We finally completed an agreement, and it was purchased by Northeast Georgia Health Systems. So that's where we are today. Now, during that time, the original hospital, there were only about 3 to 5 physicians that were here that were started with the hospital. And that, in 1978, the hospital kind of got in some financial trouble. It's one of the themes of our history, and like many other hospitals. And so we brought in a management team from Quorum, or HCA, and that was a requirement placed on the hospital authority by the county. And so that led us up to 1991. In 1991, there was approximately 25 physicians here. And I'm going to refer to them as community physicians. They lived here, they worked here, they had privileges at the hospital. Over the next, 17 years or so, that 2025 is a mistake, I apologize for that. But over the next 17 years or so, the number of community-based active staff physicians remained at 25. But unlike some other rural areas, Habersham County continued to grow. In 1991, the population was approximately 33,000. Now it's getting close to 50,000. We're up around 47,000. So we've had a pretty stable growth throughout this whole time, fortunately. However, our medical staff did not grow. That asterisk up there is mainly the way we were able to accommodate the increased growth and the increased number of patients was with nurse practitioners and PAs. And while I was on the healthcare board, that was a really hard thing to track. We could track physician licenses and physician surveys. So I hope that with the name change and the able to maybe assimilate some of the nursing data and the PA data, that we were able to get better numbers so we could really tell what was happening as far as workforce in the various counties in Georgia. So that was, that was kind of the beginning of the end. We had this great facility in 2008. You might compare it to an airline that had maybe a couple of dozen brand new 737s or 777s. We had all the facilities, but we didn't have the pilots to fly the planes. And I'm not trying to overemphasize physicians, but you have to, that's part of the solution, along with nurses. I mean, we have to have personnel. So from 2008 to 2023, the number of full-time physicians living in our community, calling this their home, that were on active staff here, dropped from 25 to about 10. Now, we were able to run the hospital because we had doctors that came in, doctors that staffed our hospitalist service, doctors that staffed our ER. In that same time period, from 1991 to the present, we went from approximately 10 surgeons that were fighting for space in 3 ORs to 2 to 3 surgeons that were working out of 5 ORs. And that's, if you're spending that many millions of dollars and you're building a 24-bed outpatient surgery unit, that's not a way to make your investment work. So that was one of the many contributors to what led to the dire financial times that we experienced in the last year, to where we were down to less than 1 day's cash on hand. The huge threat of the facility closing. So fortunately, that didn't happen. We were able to work with Northeast Georgia Health Systems, and we're on our way up again. So now there's a lot of benefits to practicing in rural areas, and I just wanted to touch on some of those. You can make a meaningful impact in your patients' lives. You get to see and interact with them on a daily basis. It really gives you accountability. My wife likes to joke about how many patients I see when we go to Walmart, and being an OBGYN, sometimes those conversations are not, probably not for Walmart, so. But I feel like in a rural area, it's easier to have a better life-work balance, to be able to raise your family, do the things you like to do, to your hobbies, to do recreation outside. One of the first weeks I was here, of a doctor who had been here, a younger doctor, he later became the mayor of Clarksville. He took me to go fishing, and here I am practicing OBGYN in a small area. I'm on call, and we drive up about 10 minutes from here, and we wade into the waters of the Sequoia River, and we're fly fishing, and a deer walks across the stream right when I caught a fish, and it was just kind of surreal that you can do this and be on call. It's maybe a little more challenging to do that if you're in Metro Atlanta. So well, you don't have to, but the Chattahoochee's a lot bigger down there. We have less traffic, less crime. I have a 5-minute commute to work through 3 stop signs. And I was thinking about it. A lot of people probably practicing in Atlanta have a 30-minute commute from where they live to where they work in the hospitals. And that's, by Atlanta standards, that's not really bad. But if you look at that's 30 minutes each way, or an hour a day. That's 5 hours a week, or 250 hours a year. That's almost 6 weeks that you're in the car. And so I like my 5-minute commute. I mentioned the recreational activities, and also an opportunity to become really part of your community, to do the things that are your passion, and to have a meaningful impact. As far as recruitment, there are various levels that you can focus on. Dr. Burke this morning shared with me a great story about how his community hospital basically paid for a local local students to go to medical school, and that student came back and was able to pay back that debt by working. So that's a local opportunity that communities have to affect their physician workforce. So the community can be involved in recruiting. Individuals who have relationships with the hospital can involve them when they're interviewing doctors, especially board members. When I was here, the board members, that was what they do. They took prospective doctors out to dinner and told them about their community, what it was like to live here. Local businesses should get involved too, the Chamber of Commerce. Banks and realtors certainly have a very vested interest in recruiting physicians to come practice in a community. At the state level, and this is where a lot of thought was placed, especially on the workforce board. There are many things it can do, and a lot of them involve money, but others don't. The tax credits, I think there are tax credits available to physicians who practice in rural areas. I don't know how effective those are. Loan repayments are huge. I think that's a better way to focus. When we were on the Physician Workforce Board, there were a lot of scholarships that people were given when they first start to medical school, and they may think they're going to medical school to be a primary care doctor or work in a rural area, but they may want to be a specialist, and you don't know until you get there. So if you took a loan to go to a rural area, but Habersham County or Eastman, Georgia or Bainbridge don't need neurosurgeons, so you're kind of out of luck. And if you don't repay those loans, you have to pay triple damages. But those we've kind of phased those out, and that's been an improvement. But loan repayments, everybody has student loans, and so that's a way that the state can help to recruit physicians to rural areas. In 2005, around that time, the malpractice environment in Georgia was very bad. We only had two companies that were basically insuring physicians here, but through some meaningful tort reform that we got done at that time, we were able to make it a better environment here, and because of that, many other companies were able to come into Georgia and help insure physicians, and in doing so, the malpractice insurance rates dropped, that was a good thing, and that's something that can be done at the state level. And then Medicaid reimbursement. The Medicare reimbursement rates for Georgia should be compared to definitely the surrounding states and other states in the South. And if you want doctors to come practice in Georgia, you should try to make Georgia the most attractive state in the country to practice, and you can do that with some of these things. That's just a goal that when you're looking at staffing Georgia and staffing the rural areas, that's one kind of test to see if it's going to work. Is it going to make Georgia more attractive than other places to practice? Medical schools have a big role in recruiting doctors to rural areas, encouraging primary care. I think Mercer Medical School is a great example of that. They do an incredible job, and students coming in there know that that's kind of the route. Rural scholarships are helpful, and also getting the students out into rural areas to work with community physicians so they can learn what it's really like to practice in these areas can be very effective in helping to recruit to rural areas. GME, or graduate medical education, is probably the biggest opportunity. We surveyed doctors when they were leaving residency about where they were going to practice, and where they did their residency was basically more important than where they went to medical school and even where they were from. So getting those graduate programs into regional areas is a huge step. So it used to be Augusta and Atlanta were the only places you could train in Georgia. Now we've got Macon, and we've got Savannah, and we've got Gainesville, and a lot of other I believe Rome and Albany, so lots, and even Colquitt County, and they've really done a good job in trying to get those residents educated in the rural areas so they'll be more likely to stay there. I'm really excited in Gainesville, which is about 30 minutes down the road. We've got several residency programs, especially family practice, emergency medicine, general surgery, which is greatly needed throughout the rural areas. So hopefully some of those graduates are going to be coming to the rural areas. So in conclusion, communities and hospitals need to identify the doctors that they can bring to their areas, but those doctors also need to know that that's where they want to go to. So you can't put a round peg in a square hole. We can't sell Habersham County as Atlanta, and Atlanta can't try to serve a physician that really wants to be in a rural area too. And there's lots of ways to do that. If we can maybe tear down some of those silos that were mentioned and get other agencies to work together, all for the common goal, it would be a great way for everyone to work on the same page and everyone to run the relay race. The first speaker this morning did a great job. She presented so much information, and I hope I haven't been too redundant. So, any questions I could answer?
Senator Patrick.
Thank you for what you do in the trenches every day. It matters a lot. And I didn't realize until you said you'd been in practice 30 years, which is how long I was in practice before I retired, that I'm old enough to be his mother. But but what I was going to second what you said about graduate medical education. I think that's a key piece of the puzzle that we can do more with, because medical school is one thing, but where you do your residency matters a lot in terms of whether you stay or go. One question I had is the number of doctors the attrition over the years was very startling to see on a slide. Was that just people aging out, or was there something else going on?
It was some aging out, some moving to other locations, just not getting the support they needed. But yeah, that was basically it. I don't know, it's a number of factors that went into that, but it was a fact. And that, again, you can't have a great facility unless you have the personnel to work it. And you have to. Well, it all boils down to the patients. You have to have patience if you want a successful facility. You have to have patience, and without the physicians to bring those patients to the hospital, it's you're not getting your return on your investment. In addressing your point, in the Medical College of Georgia OBGYN program, residency began sending doctors to Rome, Georgia, to do rotations there, because they're just not getting the number of cases that they need to satisfy their residency requirements. And I've been also able to have those residents come rotate with me and operate with me just to get those. And they've been effective in Rome in helping in basically retaining some of those residents. They get to see what it's like to practice in Rome, Georgia, and some of those graduates have gone to Rome to practice. So we've started that here, and hopefully we'll see those same fruits of our labor.
Any other questions? Senator Walker.
Dr. Hatchett, thank you for your presentation, and it's great to see you again. I have recently visited in Dublin at Fairview Park Hospital with the CEO over there, Don Avery, and his senior staff, and the other Chairman Hatchett, Matt Hatchett, and I met with them, and they've made a real concerted effort for really decades now on physician recruitment. And just from the outside looking in, it appears to me that, well, they've been successful doing it, first of all, but it appears to me that it's been a real community effort over there, and that the community recognizes the value of bringing in physicians and how it impacts their quality of life, their health care, but also their economy, and so the whole community's got behind it. So I think that's a real valid point that you made on the community part. I do want to. Are you familiar with the program, the rural physician program that Mercer University has? I think Governor Deal started it, but they also have a rural physician scholarship program that's been successful. Do you know about that, or?
Yeah, a certain brother of mine works kind of for Mercer too, and he may or may not have made a phone call to me about a graduating resident who in OBGYN who had the Nathan Deal scholarship, and so I may or may not have made contact with this resident, and she may not have, or she delivered she did 2 C-sections this morning while we were meeting. So she joined basically. I had my practice here for 30 years, and it just became necessary, for one thing, to recruit other doctors. So by joining with Northeast Georgia Medical Center, I was able to recruit Dr. Howard to join us. So I think that's a great program, and Dr. Howard's been a godsend. So that's super, and it's ironic that both she and I live in the Clarksville area, only about 5 or 10 minutes from Governor Deal. So I'm trying to arrange a breakfast so we can all get together.
Well, thank you.
Did you have a question?
Yeah, thank you so much, and great to meet you for the first time. We enjoy working with your son and your brother, I take it, in the house. What's the impact of I mean, over and over, doctors that deliver babies are going out of the business, and how does that impact the whole? Where does that play in the dynamic of keeping a hospital and a medical community viable with services? It's, a vital, fundamental service that we're going to need. Babies are going to keep coming.
Yeah. I mean, you're looking at the start of life,
Mm-hmm.
and I can't. I'm not a hospital administrator, and I don't run hospitals. But I heard it from previous administrators that if you can take care of a mother who's having her baby, and you do a good job of doing that, then she's going to bring her baby back to this hospital if the baby gets sick or if she gets sick. And then she's going to, if her husband needs medical care, she's going to bring her husband here, because the women often control the health care in the family. And then she's going to bring her parents or her in-laws to here. So if you can start with that initial, the labor and delivery and the emergency department are usually the 2 doors that most people get their first experience in a hospital. So if you can do a good job delivering babies, as well as the emergency department, you're more likely to have a patient for life that will patronize your hospital.
Mm-hmm.
So it's very, very important. And it saddens me, the hospital in Stevens County, which is only 20 minutes from here, their labor and delivery was forced to close within the last year or two. And the farther a woman has to go from her home to deliver a baby, the more likely she is to have an adverse outcome.
Mm-hmm.
If you're less than 45 minutes, you've got a pretty good chance. If you're over 45 minutes, which we have patients in northern Rabun County, that we're basically the closest hospital to them, and some of them have are high-risk pregnancies. So we can still take care of them, and I'm hopefully that this practice is going to continue to grow, and we'll be able to do that. But I don't think they should have to travel 2 hours to the main campus in Gainesville or even to Atlanta for care, because bad things can happen. That's another opportunity for telemedicine. Telemedicine has there's some things it does not so good, but some things it can do very well, and allowing women to have consults with perinatologists, high-risk pregnancy doctors, or for babies in rural areas to be able to use telemedicine for them to get the recommendations from neonatologists. It's huge. It's a huge opportunity, especially in rural
And
areas.
how has that played out in this hospital setting? what you just described?
Well, we had that service, the telemedicine, where we had a physician in Atlanta that was providing that service, and the patients, instead of having to go to Atlanta or Gainesville, they would just come here to the hospital, just right across the hall, and they would see a sonographer and have an ultrasound, and the physician could look in and see that live, and then have an interaction with that patient there. So it saved many people like 3 hours commuting to see a physician. I'm trying to be the squeaky wheel to keep that service going, as well as to begin the neonatal telemedicine. I just think that's a great opportunity. With a nurse practitioner here in our nursery, we could have a conference with a neonatologist in Gainesville or anywhere, and take care of a baby, because it's not always that hands-on that you need. You need the expertise on what to do with the current situation, what the current condition, and just you need guidance, and that's where the telemedicine can really be helpful.
Any other questions? No? Thank you very much.
I'm available afterwards to tell stories about the chairman when he was growing up.
That's been in the agenda.
Thanks, Dad. All right. Next is Diane with the Chief Human Resource Officer at Northeast Georgia Health System.
Is it okay for y'all three?
Yeah, come on up. And thank y'all for hosting us today.
It's our pleasure. Absolutely. Looking for our third chair. I'm sorry?
You want us to? We good? Okay.
We have a third member, and it's Diane Poirot. So I have
I didn't want to butcher your last name. I'm sorry.
If you are an Agatha Christie fan and you like Hercule Poirot, it's the same last name. So either people butcher it or they're like, oh, "Are you related to Hercule?" And I'm like, "That's a fictional character." So, so no, I'm not. And I've got my colleagues here, Melissa and Nicholas, and they'll introduce themselves. Have we got the PowerPoint ready? And while she's pulling that up, I just want to say, as you know, Northeast Georgia Health System has two rural hospitals, Lumpkin and now Habersham, and they are very much critical to our overall plan for the area. A lot of people, a lot of healthcare organizations are looking at smaller critical access hospitals so they can have referral patterns for specialty care. That's really not part of what we are doing. We already have about 85% of the market in the Gainesville area. We don't need more business to come to Gainesville. We just need these services to be provided closer to home. And quite frankly, we wouldn't be able to. Our emergency room is packed. As you know, we're always packed in the hospital. We've already done semis, so we're doing 2 beds in 1 room, which is very unusual. We have not gone on diversion at all in the last year. So again, having the rural hospitals is critical to being able to serve our service area. So we are very passionate about ensuring that hospitals like these not only survive but thrive. I am going to talk a little bit about nursing and the state of nursing right now, and a little bit about that. Do you need? I do have a. Okay, I was going to say I brought a thumb drive. Okay, so.
Came prepared.
I do like to come prepared. I'll talk a little bit about the state of the workforce right now in Georgia, so you know what we're dealing with. Then Melissa's going to talk about some of the initiatives that we've done at NGHS, and then my colleague Nicholas will follow it up. He's the director of physician recruitment, so he's going to talk and elaborate more on what Dr. Hackett was speaking about and some of the efforts there. And I only wish we had brought John Dalzell, who is over our GME program. I think you would love to hear from him. So if you got it. Okay, you can go to the next one. And so just to kind of look at Georgia nursing by the numbers, first of all, there's 101,465 RNs and LPNs currently employed in the state of Georgia, and only a 1.2% nursing unemployment. And that assumes that 1.2 actually wants to work in nursing. We've seen a lot of people that have left the profession. Especially, we saw an accelerated leaving of working for healthcare providers during COVID because it was very, very difficult. In 2010, there was 6,914 nursing jobs posted in the state of Georgia, and that's when we thought we had a crisis, okay? Last year, 34,501 jobs posted, nursing jobs posted in the state of Georgia, and of course, we can't fill those. So again, assuming the 1.2% want to work, that's only about 1,200 nurses. It certainly will not fill the 34,000. And then over the next several years, the next decade, Georgia schools predict to graduate 705 RNs and 228 LPNs, but it still will not fill the need just over those next 10 years. We'll be short 133 RNs every year, and we'll be short 22 LPNs. And that assumes LPNs are going to be not at the bedside. What we've seen is LPNs were doing team-based nursing about, 5, 10, 15 years ago, you saw an exodus of LPNs from the bedside, from the hospital, going toward an RN model. Now we're reestablishing team-based nursing, but we just don't have the LPNs to be able to do that. So a lot of what we have are contract LPNs that are coming in from outside the state, which of course we're paying good money for. I mean, a lot of money for that. A lot of money for that. And but if that's what we need to do to take care of our patients, of course, that's what we're going to do. And then going to the next slide, talking about the top 5 concerns. So this is the top 5. So it's not going to add up to 100% because it's the top 5. So the market shortage of qualified RNs, that's the nursing leaders' the top one of the top 5 concerns. Again, we're not going to have, we thought we had a shortage. Now we know we have a shortage, and we're working through that. A big one now is the abuse directed at nurses, and I'll give you a little bit more data on that, but we see that I am reporting out on employee injuries almost every day to leadership, and I'm usually reporting out on physical assaults, verbal assaults, gesture assaults, even sexual assaults. Increase in nursing labor costs. And again, we've seen that because of having to bring agency in. Agency typically, if you were paying a nurse about $40 to $50, agency would be maybe $65 to $75. We saw prices go as high as $225 an hour during COVID, and we still have not gotten down to pre-COVID numbers. So a lot of people, they just want to travel so that they can keep getting that higher amount of money. Unresolved RN burnout. We know there's physician burnout. We're doing a lot for that. But there's also RN burnout. It's been really, really difficult over the last 3 years. And so again, getting people the time off that they need to go and take care of themselves, it's really difficult when you don't have the staff there that you need to take care of the patient. So we really have to get quite creative with that. We've been trying different strategies, not just to develop, but for staffing and for scheduling. And I'm happy to answer any questions about that. I can get real geeky about that, so I'll warn you that now. Again, I just talked to you about the academic pipeline will not meet the projected demand. And that is not just for nurses, that is for respiratory therapists, it's for diagnostic imaging, it's for all the clinicians and allied health professionals that are going to be needed to take care of the patient population. And then further, nurses are worried about recruitment of the unlicensed workforce too. Okay, so if you don't have somebody to clean that room, if you don't have somebody to cook the food and pass the tray, and right now because we saw unemployment go so low, that's becoming really, really difficult to get people to take those food nutrition services. It used to be we paid more than fast food and we offered benefits and everything. Well, now fast food is doing $15, $17, $18 an hour and a lot more flexible schedules. And so again, making sure that we have that staffing to cover the non-licensed is just as important. And so, again, I wanted to give you some data about workplace violence because it's a hot topic right now in healthcare, and it's a hot topic with the people that work for us. This comes from a Premier Workforce survey that was done this year, February to April, and the percentage of workforce directly involved in a workplace violence incident in the last 2 years, 40% of the 669 people that took the survey reported that they had experienced a workplace violence event. And then you can see nurses got a little bit more of the brunt of it. So out of that 669 people, 43% we experienced violence, non-nursing, but 65% of the nursing in that group said they experienced violence. 47% of the all respondents said, yes, emotional verbal abuse. 34% said, yes, it was nurses. And then again, 53% physical or sexual abuse, 66% of nurses felt that. And there's a lot of reasons that I'm sure my nurse colleague here could talk to you about. There's patients that, they may be a correctional patient. They may be a social patient that right now there's not a place to put them. And so nurses are still dealing with these folks, even though they may not need to be in the hospital anymore. And then if you want to go ahead. So there was another data there with Press Ganey. And Press Ganey actually surveys hospitals. They don't survey all of them, but out of the 483 hospital systems in their database, they collected data for just 3 months of last year, and over 5,000 nurses in that time period had stated that they were in some type of workplace violence assault. And again, in this particular one, it was forcible, unwanted physical or sexual contact, whether or not there's intent to harm. That's not being yelled at. That's not, gestures. And we look at all that because we consider all of that assault. And so the question becomes is how can we take all of these facts addressing our landscape in healthcare right now and really not just provide for the big hospitals, but also the critical access hospitals and so forth, because this stuff is happening everywhere. And so we have to be cognizant that the nurses that are coming into the workforce, the doctors that are coming into the workforce, the non-certified people, they're all worried about this. And so what can we do to address this? Obviously, we can't just wait for nursing schools to admit more nurses, or we have to be proactive and start doing some of these things. And so with that, I'm going to turn this over to Melissa Rouse, my colleague, and she's going to talk to you about some of the things that we've done at Northeast Georgia to address this. And again, these things will also impact rural hospitals.
I'm going to just pause for just a second. I think Senator Kirkpatrick has a
Just
question.
one thing I just wanted to point out is that we had a study committee on violence against healthcare workers, and we did pass legislation on it this year.
Yes, you did.
So we are doing something.
And let me say that I do appreciate it because we did get to offer some feedback on that legislation, and I appreciate that there were some things that might have been onerous to report, and you listened to us, and we really appreciated that. We want to take active steps to make sure we're addressing workplace violence, but not necessarily more reporting that takes up resources. And we want to be able to report the apt amount of report, but we don't want it to be so onerous that it gets to be difficult to manage. So really appreciate you taking our feedback on that.
Thank you.
So good afternoon. I'm Melissa Rouse. I'm the Executive Director of Nursing Excellence and Research. So recruitment and retention has always been an issue, right? We've always been concerned about that and have always had plans on how we're going to meet the workforce needs. But more significantly, over the last couple of years, it has just grown and grown into those statistics that Diane just shared. So in early 2022, our Chief Executive Officer kind of called a group together and said, hey, we've got to have a plan, like a really strategic plan over these next 5 years of how we're going to tackle this. And so we had multifaceted plan related to that. But one of the things that I was tasked with was pipeline. They said, Melissa, go be creative and figure out how you're going to do this. And so I went to my partner schools. University of North Georgia is one of our partner universities. We have come alongside them and have committed funding for the next 5 years for them to create an accelerated BSN program. So that's a program where if you have a bachelor's degree, you can become an RN in 15 months. So it's like a second degree program to become a nurse. And so we partnered with them to hire faculty to get that program up and running, and now are hoping to recruit all of those folks into Northeast Georgia Health System. I also met with our technical colleges, and we really put our thinking caps on around how can we get workforce out quicker. And they had a summer program for their CNAs. It was an 8-week summer program, and that was the quickest route to get a CNA. And so I said, what if we offered that over and over and over throughout the year? Could we do that? Could we create a pipeline in that regard? And so we started it. It was a hit, and we've been doing that since 2022. North Georgia Tech then said, hey, what about us? We want to do this too. And so now they're offering that 8-week accelerated CNA program. And then North Georgia Tech really has been a great partner in listening to where our needs are, not only for nurses, but also for LPNs. And so we've got a program running with both Lanier Tech and North Georgia Tech to get LPNs in a quick fashion. In a 1-year program, they are ready to come to work for us. Then, as you think about pipeline, the LPNs are saying, well, what about us? Where is our career growth? And so North Georgia Tech recently, you may be aware, recently got approved for a LPN to RN bridge program. And so they'll soon be accepting their first class, and that will get us a nurse quicker. So lots of creative opportunities in really partnering with our schools to say, how can we help you help us to get this pipeline moving and create nurses that we can hire? And then Brenau University, who sits right in our backyard in our Gainesville campus, has really come forward and said, what about us? We want to be part of this too. And so we're looking at some innovative programs right now to be able to partner with them. So next slide, please. in looking at our pipeline, we also kind of just got together and said, okay, any idea is a good idea. Let's just throw ideas out there and let's just brainstorm. And as we were talking about the competition of where people are going, you know, they're going to work in fast food and they're going to work in all of these other areas other than healthcare. And we said, what if we lower the hiring age to 16? Well, imagine that. Like, people are like, whoa, wait a second. 16-year-olds running around the hospital? That can't be. But we said, no, we can do this. We can create a safe environment for them. We can train them to do the things that they need to do and give them that entree into the healthcare system. And so we do have a lowered hiring age now. I'm excited to say we have a nice training program for 16-year-olds. You know, many of them, if you have 16-year-olds, they need life skills. And so we've done a really nice job of getting them into the health system in whatever capacity they're interested in, and now they have career opportunities to grow with us at Northeast Georgia. The advancement programs that are listed there are the ones that I spoke of a minute ago. So the PCT and LPN program, we partner with Linear Tech and North Georgia Tech. Through the generosity of our foundation, as well as the funding that we have budgeted through Northeast Georgia Health System, we are sending these folks to school. We're paying for their tuition, their books, their uniforms, their fees, everything. It's a game changer, and it had just such powerful stories from these folks about how this has changed their lives. So in 8 weeks, they can become a patient care tech. They sign a contract to stay for 2 years with us, and our hope is to continue them on the pipeline. So we have the PCT advancement program for a non-licensed person. So if you work in our hospital in dietary services or environmental services and you think you might want to get into healthcare, this is a program that can help you get that start. We also recruit from the outside. So, you know, we didn't want to just be robbing Peter to pay Paul from within. We want to bring new people into the organization. And so we've hired folks into these positions as well. Our LPN advancement program, we require that they have a CNA so that they can work part-time while they're going to school. So same program where we pay tuition, books, fees, everything. And they work part-time and then are paid a full-time salary so that they're paid for the time that they're studying and doing clinicals and things of that sort. So in 1 year, we have an LPN out of that program. We just had our first one graduate. We're very excited. And we have 7 that just started this fall that will be going through the program. And then the next step of that is our PCT to RN program. We're getting ready to launch that for the fall. We're putting all of our publicity together right now to start recruiting for that. So that program will be similar to the others, and that will pay for all of those things. We're going to partner with our tech schools because we can get an RN quicker. So instead of going to a 4-year program, they'll go through the 2-year program. And so Linear Tech and North Georgia Tech are very excited to partner with us in that. And then the LPN to RN program, that's the bridge program that was just approved at North Georgia Tech. So we have students applying for that right now. So very proud of those programs. And then a couple of other creative programs that we have. The Compass PCT program is a program for nursing students who want to come work in the hospital over the summer. So it's a 12-week program. They come in, they get paid full-time hours, and they function like a CNA or a patient care tech and get real-life hospital experience. We rotate them through the department so they can find that department that they're really passionate about, whether it's the emergency department or oncology or pediatrics. And then at the end of that 12-week program, we hope that they'll stay on PRN or per diem so that they can continue going to nursing school, and then we'll hire them into our residency program on graduation. And then the 2 new programs that we started this year that we're excited about, the PCT immersion program is a hybrid of that Compass PCT. So this was the 5th year running our Compass PCT program. So we did this offshoot where you work for us for those 12 weeks, but you work 2 shifts each week as a patient care tech and 1 shift partnered with an RN. So now we're moving them into the RN world. They're in nursing school already. They have competencies they've been signed off on. So they get to start getting some of that real world practice. And we rotate them through departments as well. So it's that same opportunity to really find their passion and the unit that they want to be hired into. And then in partnership with University of North Georgia, we started a nurse extern program. Let me back up to the PCT immersion. That's the partnership with University of North Georgia. So while they're in the RN role, partnered with an RN, they're getting school credit for that. So it's a really nice opportunity for them to continue getting credits for school over the summertime while they're here getting all of that experience as well. Brunel is very excited about partnering with us for that for next year. So I'm hoping to take that on the road and get more schools involved in doing that. The Nurse Extern program is a program where we are taking nursing students. We'll bring them in the summer as well as in the Christmas break timeframe, that winter break, so that they can spend an extended period of time with us to get oriented. And then their commitment will be one shift every other week so that they can stay connected to us while they finish nursing school and then hopefully hire into our nurse residency program. So all different opportunities, not one size fits all, but lots of different opportunities for people to get into our health system, find out who we are, and really become acclimated to the Northeast Georgia health system and find their career path. Did you want to add?
I just want to, first of all, commend my colleague here because she's really been involved in a lot of these programs, and we can, but I do want to give one little, so you're going to ask, do these work? And so I will tell you, I've only been here for a year. We had 9,456 employees last year. We have over 11,000 employees now this year. Now, 400 of those came from Habersham, but we are still 1,000 employees to the good. We have reduced our contract labor by half, from 157 million to about 70 million. So again, these programs are working, and kudos to, first of all, Northeast Georgia Health System for funding some, also our auxiliary for funding some, our foundation for funding some. But these are great programs that are already tried and true, and if there's any funding out there, that would be great.
Absolutely. I will say that we just put our budget together for fiscal year 24, and I had to figure out, where do I want to invest in these programs? Where are we going to get the most bang for our buck? Which, of course, is the RN programs, right? Because that's where our greatest need is. But it's hard to make those decisions. And so I applied for a Department of Labor grant, didn't get it, but we'll try again, and we'll try to find more funding. It was a federal Department of Labor grant to partner with all of these schools.
Let me stop and ask you there.
Yes.
With the RN program that you're referring to, is it just the PCT to RN or the LPN to RN? Which one of those is most successful, do you think?
So we haven't started those yet. Those are starting this fall.
Okay.
The patient care to RN is a 2-year program, so that would be a quick way to get a registered nurse. The LPN to RN is a 17-month program, so they're already a licensed practical nurse. They just need to get the registered nurse education. So 17 months we'll have that one. So trying to figure out, which one do we want to put the most effort into to try to get an RN as quickly as possible. One of the things that Diane mentioned, do you have a question, Senator Kirkpatrick?
I just, so I'm sitting here thinking about, I couldn't get 16-year-olds out of my head, but but I was thinking about, so we're pushing people through these programs so we can have bodies on the floor to take care of the patients. What do you have ongoing to continue their education, because they're going to be green when they come out? How are you setting up for mentorship and for ongoing education? Because that experience is, that's what causes burnout, but it also is the people that you want taking care of you if you're a patient. So how are you managing?
Thank you for asking. I couldn't plan that better. So we started an LPN residency program. So for these folks that are coming out as LPNs, we've had a registered nurse residency program, which is a 1-year program to really support them transition to practice. We started one for our LPNs, and so we're heavily recruiting new grad LPNs into our organization right now and supporting them that way. Those that go through these programs have a connection with the coordinators that will continue to support them. So they're out rounding on the units while they're through orientation, and then we want to move them through all of these career pathways. So continuous development. We have, under my umbrella, we have all the nursing education, and so we do an annual needs assessment survey with our staff to see what are you interested in, what classes do you want. We have very generous programs to be able to send people to conferences, to give them all kinds of upskilling. So that's definitely on our mind, is to make sure that not only do we get them out the door and out taking care of patients, but that we continue to give them development opportunities. Yeah, really great question. The last thing that I'll touch on that side is work-based learning. And so as we were thinking about our 16-year-olds that we needed to get into the health system, I was invited to a middle school fair. And I went out and talked to them. And in middle school, as you guys know, in the state of Georgia, they're declaring this pathway that they want. And so I had all of these kids that thought they might be interested in a healthcare career. And when I went with the idea of recruiting for Northeast Georgia overall, Not everyone wants to be a nurse, but if you're in IT, if you like techie things, we've got IT positions. If you want to be an engineer, come work for facilities. If you want to be in food service, come work for our dietary. So really talking to them about all the opportunities that we have in our health system. And so we created a workforce development coordinator position. So our leadership said, okay, I see where you're going with this. Let's see what this looks like. And so we've hired this person, and she goes out to the middle school. She goes out to the high schools. She's recruiting for all of our positions, not just nursing, all positions, and linking these folks into our organization. We bring them in. They do rotations through different departments. We take our simulation bus out and get them exposed to things in healthcare. So that has really created a lot of energy and excitement for folks to come into the healthcare setting. We have hired many of the students from work-based learning. So they've come in high school, and then we've hired them into positions, because remember, we hire at 16. So it's the perfect way. It's a perfect way to get them in. I will say, too, that, we have so many great opportunities for high school students right now to go to a CNA program while they're in high school. And so they're finishing, and they are CNAs in their junior and senior years of high school, but they didn't have opportunities to go work in a health system. So we said, let's do flexible schedules. Let's take them for whatever hours they'll give us. So we have 4 hours, 6 hours, and 8-hour shifts that we can bring these kids into if they work after school or if they can only work on the weekends. Some of them have modified schedules. So we've really had to get creative around how we create opportunities to recruit folks into our organization. So those are the programs that we have going right now. They are just hitting the tip of the spear in what we need, of course, but at least, we're getting some momentum and getting things moving. If you can move to the next slide. This is just a little bit about retaining our employees. And some of these things we've talked about. Senator Kirkpatrick asked about those career pathways. We have a lot of leadership initiatives about connecting with your employees and making sure that they are happy, that they're adjusting, that it's the right fit for them. Having those 30-day, 60-day, 90-day check-ins, and then those monthly or quarterly check-ins to see where our employees are. And we're having conversations with them about, how do I help you get to that next step? What is it that you want in your career path, and how can we find that for you in Northeast Georgia? Pay, Diane talked about pay a bit. We've come up with some creative programs for people to work PRN or per diem. And so we have 4 levels now, so they can pick the level that they want to work at based on how much commitment they want to give us for hours, and the pay increases with the amount of commitment. So again, a flexible way to really help people with work-life balance to really meet the needs of their families.
Are you saying that the pay per hour increases?
Yes.
If you take higher number of hours?
Yes, exactly. So let's say you commit to 3 shifts a pay period, you make a certain dollar amount. But if you agree to 6 shifts per pay period, you make more money. And if you agree to 8 shifts per pay period, you make even more money. And then 12 shifts. So it goes up as the different levels go up. So that's appealing for people. If you've got kids in school and you can't work a full-time schedule, but you still want to commit to the organization. And then that first dot point, Crisis Prevention Institute, Diane talked a bit about the violence that our employees are facing. Our staff has said, we don't feel safe. We need things put into place to make us feel safe. And so we've offered this Crisis Prevention Institute. We put almost 1,000 employees through that last year, and we're on target to bring 500 through this year. They've asked for increased security, and so we're trying to increase security presence. We've put some things into place around a badge that you can push a button on for a panic button, and it's got some RTLS so we can find you. Security knows where you are in the building. So lots of things being put into place to help increase the workplace safety. Next slide. This is the voluntary turnover. So all the work that we've been doing around pipeline and retention, really, it's a constant cycle, right? So if you're short-staffed it's hard to keep your staff because they're exhausted, and so they leave. But as you hire more staff, you get happier staff because they have peers, they have people there with them, and so it's all interrelated. And so this is our voluntary turnover. You can see that the national benchmark is 18.8%. We started at 16%, and we really were not happy with that, and have worked very hard to get it down to 12.9% turnover for our full-time and part-time staff. That's overall staff in the organization. And then the next slide is our nursing turnover. So as we're talking about our nursing staff, you can see the benchmark at the top there is 18.2. We were at 16% in October of 22, and we are now at 11.3. So we've really done a lot of work to recruit and retain. Thank you. It's been a yeoman's effort for sure. Lots of good work around that. Yes, it is. And I think it's just proof that these programs speak volumes, right? And so even if we're only putting 7 people through LPN school, everyone sees that and they're like, wow, they're trying. They're trying to do things to help be creative and create some new processes for us to get staff in here. And then my final slide, this next slide, is just some opportunities. You know, I was thinking about what can the state do to help? What are some ideas to really help support the programs that we're starting and the programs that we need to continue with? Increasing that workplace safety is at the top because that is first and foremost what we hear from our staff. I know a lot of work has been done, and thank you for that, around protecting the identity of the injured. You know, staff is sometimes hesitant to file that police report because it's public record, right? And that bad guy can find your address and come to your house. And so we've heard stories of those types of things. And so staff, it goes around and people talk, right? And so then they're afraid. Harsher penalties are certainly something that our staff is asking for. And then funding for increased security. You know, just like every department, security is challenged as well. And so we need to make that enticing so that security officers want to come work in the health system to be there to help protect our staff. And then ways to attract to the Northeast Georgia region, you know, to Georgia overall, but certainly to the Northeast Georgia region where our hospitals are, you know, incentivizing. And I think Dr. Hatchett spoke to some of these things. So it's nice to see the same themes, right? So student loan payback, whether they go to school here or we recruit them in from outside, being able to help pay those loans back. State tax incentives. I have lived in California, Florida, Texas, and now here. And my husband is a retired veteran, a disabled veteran. And so state taxes are something that are quite appealing as you move from state to state, and benefits around things like the toll road. Any of those types of things that make a difference in that monthly income. Car registration breaks are an idea, you know, housing incentives. I think just anything that makes it more appealing to come to this area. And then I think Dr. Hatchett touched on just really selling the beauty of Georgia. I've been here for almost 2 years. I did not know where Gainesville, Georgia was when I was recruited out here. But I said, let's go check it out. And I got here and I was just in love. I absolutely love this. This is my favorite place that we've ever lived. And my husband has started a business here and we are planted. And so we are committed to making this the best place possible and bringing as many people as we can here. I'm recruiting like crazy.
Thank you, Melissa. My name is Nicholas Benton, the Director of Physician Recruitment for Northeast Georgia Physicians Group and Georgia Heart Institute, so both of the 2 employed medical groups at Northeast Georgia. And I wanted to, I guess, build on surgical recruitment. I know that that was a focus of this committee, and so I kind of wanted to double click on some of the challenges, what the landscape looks like as we go out to recruit a surgeon, keeping in mind that we're recruiting on a national stage when we're recruiting a surgeon. We're not recruiting locally. So I pulled some data from the American College of Surgeons, and per capita supply of U.S. general surgeons declined 18% from 6.4 per 100,000 population to 5.2 100,000 population between 2001 and 2019. Rural areas declined 29.1%, and small and isolated rural communities declined 32.6%. So that's very dramatic as it affects rural communities. In addition, 48.8% of urban general surgeons are over 50 years of age, compared to 55% in large rural areas and 59% in small rural areas. In 2019, 60.1 of non-metropolitan counties have no active general surgeon. Approximately 1,000 general surgeons graduate each year. Less than 20% of those actually go into general surgery. Most of them go on to do fellowships, to do something more specialized. And estimated of the 20% that go into general surgery, about 12 graduates a year end up in a rural setting. Nationally. We're talking about the national stage. And to give you an idea of the number of openings for those 12 graduates, there's 1,700 job openings in the rural U.S. So that's, just wanted to kind of paint a little bit of a picture of what we're working with when we're talking about recruitment of a general surgeon. And this is not unique to general surgery. I'm just highlighting this particular specialty. Next slide, please. So a little bit to build on kind of what Dr. Hatchett had mentioned. Thank you, Dr. Hatchett. How we recruit to rural communities and the things that my team focuses on and the incentives that we try to promote that are available to us. So one of the things is we try to utilize the rural health care initiatives to include both the state loan repayment plan, the LRP, and we also focus in on the J1 waiver program. As in addition to that, we incentivize our physicians through signing bonuses, loan repayments. I think Dr. Hatchett had mentioned sometimes if we have someone that's interested in practicing and they're going into a fellowship and they're from Habersham, let's say, we'll go ahead and sign them really early and we'll provide them an income stipend while in fellowship to go ahead and get them to make a commitment. So it's just some unique things that we try to help lock in those physicians that want to come back and practice in rural areas. We also really focus on the positive. So some of the things that Dr. Hatchett had mentioned, the lower cost of living, the idea of the hometown hero. So he's at the Walmart, everyone recognizes him, everyone's asking him questions. These physicians are very valued in the community, and that is really something that we try to sell, right? You're going to make a huge impact. You're not going to be one of 500 physicians. You're going to be one of a very small community. In addition to that, we also highlight your professional independence. A lot of times as a general surgeon, you can practice a more full scope versus if you're in a large metropolitan area, you're going to be very limited. You're going to be doing very limited procedures, whereas in some rural areas, you can practice a more full scope. Obviously highlighting it's a great place to raise a family. And then of course excuse me, I need some water. Yeah, the abundant recreational activities. Another really important piece is the current physician involvement. Thank you, sorry.
People that are already.
So the people that are already here. So there's nothing more difficult than recruiting your first physician to a community. So if you do have a medical community, we try to make those connections. A lot of times we're making connections with board members, with local government, the mayor. Sometimes, I've recruited in some really rural areas where we're hosting physician dinners at the mayor's house or at a physician's house because we may not always have, a lot of places to take someone out to meet colleagues and things like that, which is a part of that whole onboarding and recruitment process. Keeping in mind, we're also recruiting the family. It's not all about the surgeon. We're recruiting the spouse and the family. So we've got to talk about schools. We've got to talk about cost of living. We've got to talk about housing. We've got to really focus on a lot of different aspects to that physician to sell the position. And this is not a lot different than what we do in more of our urban environments, but we just have to focus a lot more on the community and all the attributes that are available to those physicians within rural practices. The next slide. So some of the things that my department utilizes, as I've mentioned previously, is the state loan repayment programs. So these are not without limitations, and where I thought that we could potentially talk about some opportunities where we could have potentially some expansion or otherwise. But one of the first one is the Physicians for Rural Areas Assistance Program. This is a loan repayment program that is available, and I can offer this as an option. There's a very limited window that you can apply for this, but it's available. I think it depends on the funding, and I think from the website it was under 35 at least was what was last reported, and that number may not be completely accurate, but I did pull it from the state website. I think the last time it was updated was 2017, so that number may be a little bit more or less. In addition to that, not only is that not a lot for the whole entire state of Georgia, but in addition to that, we do have the Georgia Physician Loan Repayment Program, but it's limited to those specialties in family medicine, internal medicine, pediatrics, OBGYN, geriatrics, and psychiatry. All of those are considered your primary care practices. And a lot of the programs that we have are focused around primary care, and primary care is extremely important, but equally as important as some of the subspecialties and surgeons that would not be eligible for that particular program. So in thinking about that, having an expansion of the types of individuals that could apply for that loan repayment program could be a nice incentive when we talk about attracting physicians to rural communities. The other area that we deal with is related to the J1 waiver program. As Georgia has two, or at least what's available to me within the Northeast region, are two programs for J1 waivers. The first is the Conrad 30. That's a national program. Georgia has adopted the national program, and that basically grants 30 waivers in the entire state of Georgia each year for physicians practicing, again, in primary care, primary care in the rural environment, urban environment, and specialists, but they're prioritized. There's only 30 of those waivers that go around. The application opens up in the fall. It's usually closed very rapidly, like within days, because obviously it's a very popular program where we're trying to bring in international medical graduates into rural environments to help them plant roots and establish relationships. It's just a pathway. It's not our only pathway, but it is a pathway. But the way that this program is prioritized is that it's focused around primary care in rural environments. So it's prioritized for rural first, then primary care for the urban environment, and then potentially specialists if there's anything left over. But there's only 30. So a lot of times those get used up. The other program that we do have available in this area is the Appalachian Regional Commission, or the ARC program. And that opens up the additional ability for us to bring J1 candidates into rural markets. But again, it's very specific and focused around family practice, general pediatrics, obstetrics, internal medicine, and psychiatry. So those primary care practices. There is a pathway within that program that you can apply for a waiver, but it's an extra step beyond what the program was designed for. And so each of those programs, although very important, and we do utilize those and we do sell them, have their limitations as it relates to specialist and general surgery. The next slide, I know it's kind of small, but I just wanted to highlight on 3RNet annual report over last year, how that really plays out when we're looking at the J1 waiver program. This is not a reflection of the entire U.S., but 3RNet, as I understand it, partners with a tremendous amount of healthcare organizations in the U.S., across the U.S. So under their program, there was 397 J1 placements. And of those, 7 were for general surgery. And then for physician replacements, just physician placements within, I should back up a little bit. The 3RNet helps place physicians. They have a job board. They have resources that they provide to all physicians looking for work in rural areas. But of that, they only place 14 general surgeons within the rural areas. Of those 397, only 7 of those were available through the J1 program. I will double click a little bit on the J1 program in that it basically allows the physician to have ties and a commitment to the rural area for approximately at least 5 years. And we're thinking by that point, they will have established roots, they will have made community connections, and will want to stay within that community. And so that's just one of the pathways that we're utilizing.
I don't want to stop you because this is a lot of really good information, but we're running short on time because we have the 3 o'clock. But I was going to see if we could get a copy of your presentation as
Absolutely.
well. And just thank y'all once again for hosting. And Yeah, let's let Kate, or Senator Kirkpatrick.
I used to run a big orthopedic group, and one of the trends that we saw with the millennials and below is that they look at life a different way. And when they're in medical training, they tend to specialize and narrow their focus. And we'd recruit an orthopedic surgeon, he would only want to do spine, or would only want to do fill in the blank. So they care more about quality of life and how many nights they're on ER call than they do about anything else. So I think the trauma angle might be worth exploring for general surgery, connecting with a trauma commission on that. That might be a good selling point, because you're fighting these societal trends that I don't have an answer for, but I think your brainstorming needs to take that into account. Not a
Thank you.
question.
Anyone else?
Well, there's so much to react to and our time is limited, so.
I know. We tried to fit a lot into one meeting, and
But
we
it's a
really
wonderful,
appreciate y'all
wonderful
in the
presentations
information.
and great innovative approaches. I think everybody in the room's excited. From people's faces.
Well, thank y'all very much. And next, we have Lisa Jellum, Dean of Atrium Health Floyd School of Health Sciences at Georgia Highlands College. Thank you for hanging in there with us throughout the whole day.
You know, I'm in education, so I'm slightly worried you guys are going to say that I plagiarized my entire thing, but we know that it came out yesterday, but I echo the room, and I'm done, right?
That's
So,
right.
all right. Okay, so I'll go ahead and introduce myself. I'm Dr. Lisa Jellum. I am the Dean of Atrium Health Floyd School of Health Sciences. I serve out of Georgia Highlands College in Rome, Georgia, so we've alluded to, that rural workforce kind of coming to fruition. I get to see before my eyes. I've been there now for 16 years, so I've grown up in rural education. I am going to tell you I am a product of Georgia Recruitment. I came from Gillette, Wyoming, probably one of the smallest places on earth. In efforts to get my doctoral degree, a terminal degree in education, and I came here specifically because of the tuition assistance program that Georgia offers. So these programs do work, and so, I've had a lot of, we'll call it the rubber meeting the road, as far as education and leadership, and seeing some of these programs actually create, people that are going to root within Georgia. So today, I'm wearing multiple hats. I actually am the vice president of the Georgia Association of Nursing Deans and Directors. And so because of that, the Georgia Nursing Leadership Coalition is a collaborative effort of just insert all of the acronyms you see up there. If you need any of those to tease apart, I can help you. And it's really just a joint effort of all of these nursing places. So we are really trying to take those silos and really break those down, because when I first became dean, I thought it was innate to take all of the community involvement and get out into the community. I took 100 meetings outside of my office in my first 6 months of taking deanship, because I felt like, that's the way you do things. Where I come from in Wyoming, you go and look people in the eyes and you shake their hands and you ask them, what is it that we're doing right and what is it that we're doing wrong? And don't worry, I can take the criticism and I'm going to take that back. And so I was really, really excited to be a part of some kind of coalition like this, to start to actually unify the front between all of us just redundantly for 7 or 8 hours telling you the exact same thing over and over again. So I'm going to give you a little bit of the background of where Georgia nursing is by the numbers. I know my the previous slides was looking at those that are employed. I would like to bring your attention to about a 40,000 person disparity between active licensure and those that are actually employed in the state of Georgia. So we do see about 169,000 active licenses between the LPN and RN communities. And what's really important for you to know is in the next slide, when you're looking at capturing those that are employed in RN settings, about 60%, a little closer to 2/3, are looking at some form of hospital setting. So when you're looking at the shortage and the effect of which the RN specific shortage is going to affect the most, you are seeing the hospitals specifically in the rural areas. So if you needed more slides to help you look at whether or not this shortage actually occurs, we have 2010 in comparison to 2021. And so you can see that the RN job postings over time have exponentially grown in the state of Georgia in the last 12 years. I know that that's not a secret to you, but in the next slide, I think that you can paint a better picture of where you're truly seeing the disparity. So in the previous slide, you saw the metropolitan location expressed, which took 28,000 of those job postings. So it looks really large as far as the job postings, but when you tease out the metropolitan area and you're only looking at the central, northeast, northwest, southwest, and southeast, you're going to see where the disparity truly lies. And so when you're looking at what the effect is in rural Georgia when an RN isn't at the bedside, that kind of rolls down the hill. And so I'm coming from an education perspective of, in nursing education, we are seeing this just as much as they do at the bedside. When a dean is taking out the trash and you have your RN, educators doing something besides educating RNs, you end up with disparities like this because if I can't fit that workforce demand, you're going to see a shortage over time. And so we are now seeing what we thought we were going to see about 10 years ago when I started this conversation in the health sciences, that we are eventually going to see nursing education come to a big disparity in creating nursing licensure. And sure enough, we're here. So there's a couple causes of the shortage in rural nurses, one of which, and I'm speaking in behalf of what I would call a geographically unique area, because people that are getting licenses in Northwest Georgia can easily commute to the metropolitan area. And if you're looking at the disparity between Northwest Georgia and the metropolitan wage gap, a little over $10,000 if you're talking a brand new graduate, graduating in Rome, Georgia, easily can take an hour commute to hit the metropolitan area and take that $10,000 gap. So that's already causing a geographical problem for that shortage. There's also a real lack of incentive to keep our nurses in the rural areas. And so when I first became dean, I would tell you that we had a lot of, we'll call them clinical partners. We were putting them everywhere. And I am not a nurse. I am a teacher education major by trade. And I'm going to tell you, where I student taught, I would have given my left arm to be employed, because I knew who the janitor was. I knew where to, get the food. I knew if I parked in the wrong spot that, Johnny that was going to drive by would give me the head nod and I could move my car. Our nurses and our hospital workers work the same way. So where they're at and where we're immersing them in, it matters, because if I'm immersing 90% of my clinical hours in a rural area, you're going to see our students have less arousal levels when you're getting as far as into an actual profession. And that's leading to some of the burnout. And so I don't have specific data leading me towards that, but I'm going to tell you anecdotally, when my nursing students look calm, and then they get nursing licenses and then they're employed in these hospitals, you're going to see less rates of burnout, because they don't go frantically into the workforce worried about the things that you and I, as working adults, we don't worry about parking spots and little things that my nursing students are worried about, because that's one of the, what we'll call barriers for success. So in our recommendations for the Georgia Nursing Leadership Coalition is, flip my page, student loan forgiveness. So forgive portioning of the nursing student debt if they commit to live and work in rural Georgia. That's one way that we can incentivize our students for staying out in the rural areas. I don't think that needs to be a long-term commitment. As you said, I think it could be an upfront cost. And I'm going to tell you that I'm going to piggyback upon that recommendation and to tell you that I serve a community that is 44% at Georgia Highlands Pell Grant. That's a big deal, because you're talking, I get a phone call once a month from a student that's telling me I'm going to quit nursing school because of a $50 bill. And so I'm always like, wait a second, like how much are we talking here? You know, is it hundreds of thousands? We're talking $60. And so last year we saved a student with a $300 bill that was just very, very confidently telling me, it's okay, Dr. Jellum, I'm gonna go ahead and pause my nursing career. I'll come back next spring. One full calendar year, they're gonna pause their career because of a $300 bill. And so it's not just the loan forgiveness at the end that is going to capture some of our rural healthcare workers, it's in-time funding. It's access to funding that is on top of the Pell Grant, that is on top of the student loan, that can incentivize the worker to stay there, on top of, at the end, possibly doing some form of forgiveness. On the education side, you know, if you're looking at ways for me to pass through funding, tax incentives for our pre-licensure, to have some ability to have the, we won't call them preceptorship, but having my clinical rotations have some form of tax incentive for those clinical practitioners to take on my clinicals. So we have this argument, I would say once a month in the Georgia Association of Nursing Deans and Directors of what is your capacity? So if I look around the room and I say, you know, what is your capacity? And I'm talking South Georgia, they're going to say it is, I do not have capacity based on clinical placements. You move to the next school and they're going to tell you it's physical capacity. You move to the next school, they're going to tell you it's nursing educators. In fact, they'll all tell you it's nursing educators. We'll go with that's a standard answer. But when you look at true capacity, there is 19 to 20 different dynamic possibilities that I have to take into place before I say my capacity is 400 in the program at Georgia Highlands. Because I am responsible for getting 400 students from the start to the end. And I don't want it to get halfway through and me decide, well, there are no clinical placements for 200 students and I have to tell these students to move to a different place. So there's a lot riding on me falling on the capacity number. So when you talk ways for me to pass through funding and open up actual capacity in nursing education, we have talked about investing in a structured nurse residency program. So when you're talking investing into the hospital, I think that's one of the best recommendations that you know, the Nursing Coalition has come up with. Because not only are the nurse residency programs showed higher retention rates, we know that the clinical confidence is significantly higher. We see a decrease in burnout and improved patient outcomes. But you're also going to see in the next slide that we also ask that there is some form of an incentive for exactly what the previous presenters said. And so when these collaborative partnerships between the schools of nursing and healthcare providers are in place, you're going to see that this is a reciprocity agreement between the educational institution and the hospital itself. And a lot of these things you are going to see will instantaneously increase the probability that that person works within that hospital system. And so when that investment is made, that it also comes with some risk. And so in the next slide, the reason they asked me to talk is that I have recently become the Atrium Health Floyd School of Health Sciences. That investment was made over the next 5 years. It's a multi-year partnership that Atrium Health Floyd and Georgia Highlands went into to increase my nursing capacity 50%. And so last year I was at a capacity of about 200%. In 2028, I should be at 300 on paper. And I'm going to tell you that it came with a multi-pronged of benefits. And like I said, I serve a population of people that Georgia Highlands was well known as an access institution, a 2-year institution for many, many years. Our first, we'll call it run at a baccalaureate degree was the RN to BSN. It's highly popular. It's a very, very prominent program. And it was one way for us to capture all of those RNs that we had created at the 2-year degree program and get them into 4-year baccalaureate programs right there in Rome while they're working. And that has become very fruitful for us. Give you a little bit of glance of why it is that the hospital program picks somebody like me. I have 1,000 students right now that are pre-professional in our health professions associate degree, which means to me that all 1,000 of those students are prospective nursing students. And that means to the hospital that there are 1,000 students in the pipeline that could become nurses. There's a caveat to this though, is everything that we've said about health and all of the things, you can't take into account all of the things that students and adult learners and life will bring to the table. And so because of that, creativity is going to be our best friend for the next 5 to 7 years in actually performing a workforce pipeline surgery per se, because we have 3 what I'll call bottlenecks. Number 1 is at the College and Career Academy at the high school level, getting those students into proper courses in the dual enrollment pathway that lead to quicker access to nursing. That's one of the bigger things that we have worked in recruitment of the K-12, is making sure that those students are actually taking Anatomy 1, Anatomy 2 micro courses that are leading towards actual admission into the nursing program. The CNA and the phlebotomy, all of the things are super great because our students can work as they go to school. That's super important for an access institution. But I'm going to tell you that if a student takes biology 1010 or chemistry 1012 at the college level, that puts them 6 months ahead of any other applicant at Georgia Highlands currently to get into the nursing program. So advising becomes really important. The other thing is that the creation of the baccalaureate degree in health sciences has become what we thought was going to be kind of the bullpen for nurses who didn't get into our highly competitive program. They could stay. They would gain credits towards their BSN, so no time is lost, no hope is wasted, no tuition, none of that. It's all a really good thing, and they on attempt 2 then can get into the nursing program. We thought, this is the 3rd year of our Bachelor of Health Science, we thought 60 by now would be great. As of this morning, I have 298 students in the Bachelor of Science in Health Science. It is awesome because it's not just nurses. It has now become, I raise my hand, I want to be a PA, I want to be a doctor, I want to be a this, I want to be a that. And we are now creating a very affordable offer in Northwest Georgia for students to not take on heavy student loan payments. We've created relationships with the Medical College of Georgia. I serve on their advisory board, getting our Bachelor of Health Science students into things like grand rounds and things right there where those students don't have to, be completely online. They can come and do the things that a typical student. We've had high success rates of getting into medical school, and so that is something that Georgia Highlands was very, very, and the university system was very, very smart in creation to make sure that those students had a way to not just onboard into nursing, but also offboard if something was to go wrong. So because of that, Atrium Health Floyd recognized all of the innovative things that we've been doing. We have an LPN to RN bridge program. We have our RN program that has 52 years of proof of concept. And so they are offering every student in our nursing program. So my line of research comes in open educational research or resources. So that's just a fancy way to say free textbooks. And so my dissertation was written on what would happen if you took a free textbook and you inserted it into about 1,200 students. And what we found was that underrepresented bodies of people, specifically at access institutions, would score higher than those that did not. And you can think of all the logical reasons. They have access to stuff on day one. They don't have to wait for their student loans to hit. And the withdrawal rate, specifically for those that are over 25, dropped by 50%. And why I'm saying that that's so important is my average nursing student is 24.5. And so one of the things I went to the hospital to say is my nursing textbook book group thing is very expensive, and I see it as a big barrier, and my job is to reduce barriers. Could we, for every student in Georgia Highlands, go ahead and pay for that textbook? And the answer was yes. And so on top of that, they offer a tuition assistance program and scholarships that do have a work requirement, because once again, there has to be some form of reciprocity in this agreement. And that's one way for the hospital to go ahead and try to bridge that gap between them graduating and them deciding they're going to, see the world. But you may need to spend a little time at Atrium Health Floyd contractually. And that's a good thing for everyone because, like I said, we are serving a very diverse group of people that don't all need to see the travel nurse world. They just really need to immerse themselves into the practice and get all of the barriers for a few years. Some of the bigger things that I once again, this is only a month old, but I'm going to tell you that anecdotally, this is the first time I've heard this in 14 years. They gave funds for faculty retention. Okay, and with that faculty retention, not only is a bonus, we won't call it a bonus, it is an actual market adjustment of salary from the state appropriated to the market rate. This is the first time in 14 years I've heard a nursing instructor tell me or look to the future, like in the next 3 or 4 years, I'm going to do X. That is the first time in 14 years as being a part of the health sciences I have heard a nursing faculty look towards the future. It's been very, short-lived, and so things like tuition reimbursement and TAP and all of those things are great for nursing education, but really getting market rate to what it would be comparative to those around us. And I'm going to tell you that nursing education comes at you really, really fast. And so it takes 3 to 5 years until I have a very rooted nursing instructor that is pumping out very good nursing students. And so if I have high turnover, that once again leads to the dean doing the director's job, the director's doing the instructor's job, and my instructors scrambling around trying to figure out what nursing education is. And so that was one of the big selling points that I found it really is going to lead to not only long-term growth for Georgia Highlands, but actually trying to fix the workforce. And then I have any questions.
Yeah, this was very informative. Senator Rock?
It makes such a difference, the investment that was being made, that's the door opener. Georgia's one of 2 states in the nation that does not have a broad needs-based scholarship for post-secondary training. Georgia and New Hampshire, go figure. And what we've heard all day is that when you infuse the system and remove financial barriers, as someone testified earlier, it's all about the cash. When you do that, people can move forward and aspire to their dreams, and feel invested in, feel valued. So I just think that's to me is one of the big neon signs from today, and you just supported. Your account has just supported that.
I will add one more thing to this that I had in my head many, many times is we have signed a matriculation agreement with West Georgia. And so remember my pipeline had 3 blockages. Number 3 is my nursing education on the top side. So when I saw that, the hospital's really out of master's prepared nurse educators, my first thought was, why don't I try to make a way for my RN to BSN to get into an MSN quicker, find ways to fund them. I am actually now growing my own nurse educators, which strengthens my ability to do clinicals. And so West Georgia and myself, we have opened a matriculation agreement that allows our RN to BSN students 6 credits sooner to the MSN. So they can exchange 6 of their BSN credits towards the MSN. And, we've thought of lots of creative Department of Labor grants, and all of those things are on the table now that we have this true pipeline of actually growing our own in the area, because that's super important.
Yeah, just a quick follow-up. Okay,
go
this is short. We heard stories this year at the session of nurse educators, those who train nurses, people to be nurses, are leaving because they're getting paid less than what they would earn being a nurse. How are you addressing that?
With the slide before that, with Atrium Health Floyd coming to the table and bridging that gap between what I could offer as an average faculty salary. I'm at a lower end of tuition, so $95 a credit hour was super lucrative for recruiting students. But simple math would prove that $95 a credit hour doesn't allow me to keep up with market adjustments, such as in nursing education. So, I was a little kid with a lemonade stand once, and I was told no over here, so I just went ahead and said, I'm gonna walk over to the hospital and see if somebody will bridge the gap between X and Y. And they said, absolutely, because they see the value in not only making market adjustments to that level, because it will help me recruit eventually, but it's going to help me retain. And that's the long-term play for me, is to also make sure that this is sustainable. So that's my next venture, is to worry about what 2028 Georgia Highlands looks like. And so that's, what we're trying to do here, is to make sure that, those people are recognized that are really trying to fix those types of things, that really are unified no matter what part of the state you're in.
And Senator Jackson.
Thank you, Mr. Chairman. I commend the work that you all are doing. My mother taught nursing in a university setting for 30 years, and made the salary choice to do that because of a commitment to nursing. So I appreciate that others won't have to do that. My question is, we heard that for physician training, only 58% of them are staying in state, or I don't know, we've heard different numbers, but a lot of people are coming and getting educated here in Georgia and then taking that education elsewhere. What is that looking like for your nursing program? Are you raising homegrown girls and men, boys? And they staying at home, or are they going off to other states?
So the university system just invested heavily in a data program called Stepping Blocks, and according to Stepping Blocks, Georgia Highlands, 87% of those that are graduating are staying within the Northwest footprint, and so one of the 5 counties that we serve. So I don't have universal Georgia data, but I have, off the top of my head, Georgia Highlands data, which I feel as though, although you can't assume all of this could be recreated and replicated, but I've been in education long enough to know that a lot of our problems are really synonymous throughout the state, and we have echoed each other multiple times as far as I'm educating the person that I see 20 years from now at the Applebee's, and they're right here. They're calling me and waving me down when I'm kayaking on Lake Allatoona, and I know that they're staying right exactly where we educated them.
That's great. Thank you.
Anybody else?
The Applebee's.
Well, thank you very much for that.
I don't know why I used Applebee's. I haven't been to Applebee's.
Yes, thank you.
That was just great. That's really great.
All right, last but not least, we've got Chad Black, who's the chairman of the Georgia Emergency Medical Services Association.
We'll leave a copy of that Senate study committee for those 7 I told you.
Thank you.
Good, thank you. First of all, thank you for letting me come and speak on behalf of EMS for the state. I'll be brief today. A lot of what you've heard from everyone else, the workforce issues, the funding and everything else, it folds right over into emergency medical services. Back in 2007, Senator Mullis and I told you did a workforce study. You probably remember that. And a lot of that has come to fruition, even worse today. Now, some things have been solidified some of my friend Liz with the Trauma Commission and the work they've done in cooperating with us and our partnership. We've done a lot on education, but we're still struggling. And this was way before COVID hit, which just exacerbated everything for everyone in the health community. But you can go to the next one. One of the biggest challenges that we have is the same again as nurses, as Dr. Hatchett talked about, is finding people who want to come into the profession and then keeping them in the profession. We're seeing more and more, and this is nothing against the hospitals, but one of our biggest challenges now is with a nursing shortage. The hospitals have gotten smart. They've realized paramedics can work in a lot of places in the cath labs and stroke labs in place of a nurse, and they're able to pay them more for less hours, and we're losing the cream of the crop in paramedics to the hospital setting. It's hard to, when I was a fire chief before I retired, it's hard when somebody comes in and says, Chief, I don't want to leave, but I'm going to make $10,000, $12,000 more and work 20 hours less a week and be home with my family every night. Can't argue with that. You can go now and be a licensed nurse in about the same time it takes to go to EMT school, whether it's EMT B or A, and then after that go to paramedic school, come out and make double right off, and shortly you'll be making $100,000 a year, whereas a paramedic's not going to do that. So we face that. And again, I talked about the hospital issue. The technical colleges, we've got a lot that it talked about in there. Some of those in the urban areas are no longer doing EMT and paramedic programs. I was told, I've not confirmed it, but North Georgia Tech here, who has a program, could not even do their paramedic program this time because they didn't have enough to enroll sufficiently to start the class. Next slide. Some of the other challenges, public safety retirements in Georgia. You got the Georgia Firefighters Pension Fund that I'm drawing from. It's a great benefit being a firefighter retired. Georgia police officers have the annuity and benefit fund. Georgia Sheriff's Association has their retirement fund. EMS, nothing. And one of the issues with that is sheriffs and police are local and county governments. EMS, we have local and county government funded EMS, but we also have private, and we have hospital-based in the state. Now, I believe all the hospital-based, none of those currently operate under an authority anymore, so they're basically would be considered private also. So that creates challenges for us we've been trying for 20 years to do a supplemental retirement for EMS only, like the firefighters and law enforcement has, but we're struggling. And a lot of this is going to have to be looked at the federal level. We were going to hire a group out of DC to try to there's no one pension that covers city, county government, private, and hospital-based. But they were looking at changing federal law to do that. They wanted $100,000 from GIMSA to study it and couldn't guarantee us that they could get it pushed through, and there's no way we could afford that amount of money for that. Next slide. Again, some of the challenges from a national level, you've got a national fire chief through the National Fire Academy at the U.S. Fire Administration. You got a chief law enforcement officer that's the United States Attorney General. They get a lot of benefits from grants and stuff on the federal level. I got a lot when I was at Hall County and a lot when we were at Habersham. Very fortunate because we were fire-based EMS. National, there is no national EMS chief or director. That actually falls under the U.S. Department of Transportation and the Transportation Secretary. And I've never, in my 40-year career, heard our Secretary of Transportation mention EMS one time. It's planes, trains, and automobiles. So this is a major issue that is occurring. This is something I chose not to do, but mandatory overtime. You got people working, and I'll take this county where I left and retired completely back in January of 2022. We didn't do mandatory overtime, but there's 2 ambulances here out of the 6 that they run that averages 8 to 10 calls per truck a shift. Most of those transports go out of county. Now with Northeast Georgia here, I think things are going to get better. They're going to be able to keep more patients and not send out so many of the non-acuity. But that's a 2-hour call. So you run 10 calls, you're pretty much taking that up. Stats show that 18 hours of no sleep is the same as registering 0.08 intoxicated on. That's right. It is. So mandatory overtime in a lot of these departments forcing people, they've been working 24. They work the next 24, and now they're running 8 to 10 calls again. You want that person coming to you or your family after the back end of a 48-hour shift at 5 o'clock in the morning. Plus accidents are up. But again, we're going to have to, I've met with Congressman Clyde and looking at some federal things. I don't know what we're going to do, but the staffing issue started back in 2007, and you'll see in that report. Next slide. Back then in 2007, the estimated cost was, and that was right, about $500,000 per ambulance for an EMT and paramedic for a 24-hour, or for 3 shifts, 24 on, 48 off, but to staff 1 ambulance was $500,000. That is in excess of $100,000. After COVID, an ambulance that was $160,000 just 2.5 years ago was $325,000 to $340,000 today. It's increased that much, over double, to buy an ambulance. Now, the smaller vans, if you're fire-based EMS, you've got to have the boxes to be able to put the gear in the sides, the turnout gear and things like that. You can get the vans a little cheaper for services that don't participate in fire also. But still, your staffing, that's still up here around $750,000, even with that or more. GAO reported, you see, the average cost per ambulance transport was $415. Today, Medicare and Medicaid reimbursement rates are still low and about that same. It's really, we've not had really an increase in many, many years in Medicaid or Medicare.
Can we stop?
Yes, ma'am.
We did pass a bill this year that took away the license fee.
We did, and that was part of this that was hampering us. You're right. We brought that to you, and thank you for doing that, where that saved Habersham County citizens from having to pay about $18,000 a year to license all the ambulances in the county. Cobb County, where you're from, it saved him about $500,000 doing that. So that
Listening.
You are. No. Some things like that, and some of the things, and that's what I was going to point out. As I said earlier, some of the things in this report, that was one of them. We got that accomplished this year, 16 years later. The Trauma Commission, again, with Liz and them, I can't say enough about what they've done and their cooperation and working with us in partnership. We offer, through GIMSA, about 180,000 contact hours a year of EMS education that is free that comes through the super speeder fines with the money that we get from the Trauma Commission. We're the only state in the nation that we know of that offers this. We have a lot of states calling us, I know with Liz they do, about how are y'all doing this, and it's that partnership there. So if anybody in the room has got a super speeder fine, I'll simply say thank you. But slow down, please. Yes, ma'am.
UGA Athletics, you could thank them.
I'm scared to read the paper anymore, sir.
Too soon.
Yes, sir, you're right.
I'm assuming 85 and a 40 is a super speeder.
Big time, big time. Next slide.
Yeah, we'll get us back on the rails here. Yeah, go ahead.
Also, back in that report, you'll see that ambulances provide more uncompensated care than any other major healthcare provider. Back then, it was up as high as 16.5%. Today, I worked with Pete and some of us putting some numbers together. That's about 25%. So you take that. We cannot deny transport. We're pretty much obligated to transport if they want to go, but we write off anywhere from 40 to 60%. And then if you've got contractual allowances that you've got with providers or anything like that, that can be up to 40%. So it's a non-money, it's a losing game. It's at a critical stage now. Back reports are showing that 2020, 2021, when COVID was at its peak, we lost 1/3 of the workforce in EMS nationwide. And a lot of them's just getting out of it. Next slide. This is a summary from the governor's healthcare workforce. I was able to go, I believe we were in Albany and testified on that early last year. That report came out, but we are supply constrained from the workforce like everyone else. Commission members reported challenges in recruiting new EMS workers due to discouraging exam pass rates, and we do have discouraging pass rates in Georgia. Those are not anywhere where they need to be. And again, that's on a multitude of factors. It's not just one particular thing, but commission interviews back then are still the lack of access. And I know Liz talked about that earlier, the access to level 1 trauma centers and data on transportation times hamper the delivery of care. We've still got major wall time issues at a lot of hospitals where an ambulance transports, and you see all the time communities complaining that their response times are up. Those ambulances can't respond to a call when they're sitting in the ER with a patient and the ER can't take them. Down in the Columbus area, wall times can be 3 to 5 hours waiting to take a patient off a stretcher. That excessive. So when you've got, 911 calls don't stop coming in. And then that also, for services like here at Habersham, that also does the discharges or transfers from here to another facility. If they can't transfer the patient out, the throughput to be able to get beds open to get them out of the ER doesn't exist. So that's a major problem that we're running into. Capacities at hospitals, they're full. Ambulances are having to wait. So that means 911 calls are waiting. I was going to Atlanta not long ago, dialed 911 in Gwinnett County to report a wreck with injuries. And I got, you have reached Gwinnett County 911. Please remain on the line. All operators are busy. Now, can you imagine if that's a loved one and their family's in cardiac arrest or their house is on fire and they get put on hold? It happens every day because of the backup and everything. And not only that, 911 operators are experiencing the same thing we are. Next slide. I talked a little bit about the reduced funding and the consolidation of the tech colleges. Augusta and Dublin, they no longer offer EMS education programs there. And while it helps the economy of scale for the schools, it's devastating when students have to travel 100+ miles just to go to EMT or paramedic school. It's remained stagnant, the average pass rates for the EMT and advanced EMT for over a decade now. And, and we're in an industry, we just can't maintain a 35% waste factor and remain viable anymore. This is just on the EMS education. This is just things that the technical schools could do. Train capacity, have an expanded capacity to train EMS workers. Right. Hybrid course options connected to rural areas that's not at the main campus. And some of the areas here, they do that in some areas. Trying to find more instructors for EMS education is just a multifaceted problem. But reforms in EMS education, it could promote decreased ambulance response times, increase in recruiting and retention. and higher pass rates. So again, we're having problems at the education level. Here at Haversham, before I left, they're still doing it. We had to revert to doing our own EMT school in-house. Pete's had to do that with Metro. He's been doing the fire department itself, emergency services. We had to go out, and fortunately, we had some of our employees that were EMT instructors, so we're able to do that in-house, but that comes at a great cost. We do, around the state with GEMSA, offer through, again, the Trauma Commission funding. We offer EMT and EMR programs that can be done free of cost in the rural communities. We've seen a little bit of a decrease in that, actually, over the past few years. Still doing it, but still a decrease. But the rural communities, if you know, and they've talked, or Dr. Hatchett talked about it, if you can't ambulate or drive yourself to the hospital, you got to have an ambulance, and a lot of times there's no ambulances out there to take you. People are waiting. They're waiting to be transferred out to a tertiary center. It was nothing when I was here to have all 6 ambulances tied up and on a call and having to rely on a surrounding county to come into our county to respond to that call, the next one that came in. Next slide. That's it.
Yeah, go ahead. You grab the microphone.
Why do we see all the time, I'm in Atlanta, downtown Atlanta, in town, heart of Atlanta. And, but constantly, I think this is true everywhere, when a 911 call comes in, we'll have a fire truck, 2 ambulances, and a cop or 2. What is going on?
Well,
I mean, I do not, I said, these boys just all like to come out here
Nope.
and to the latest thing. I can't figure it out.
I can explain that. We've been doing town hall EMS meetings all across the state, cooperation with GAMS, the Office of EMS and Trauma Commission, and listening to the EMTs and paramedics, but also talking about issues. And one of the things I said, and I've upset some fire chiefs, but as a fire chief I can say it, we are sending fire apparatus on calls they don't need to be going on. They don't need to be going to the doctor's office for an elevated troponin that needs to go up the road to the hospital for test. We have taken 911 that was created in Alabama many, many years ago, and we have turned it into 411 on steroids. But if I come to this ER with an earache, I'm probably going to wait 2 or 3 hours, maybe if they're busy, before I see a doctor, and that's okay. But if I call 911 for that earache, I'm going to get an ambulance to come get me almost immediately. And we have created this monster that we're going to have to start looking at, you know.
Yes. Go ahead.
Thank you very much for your presentation. 911 started in my hometown in Haleyville, Alabama.
That's
Just
right.
FYI.
Thank you.
The first red phone. It's
Yes,
in the
ma'am.
Smithsonian now. This is much appreciated for you to have brought us the old study committee report. Well, what would also be really helpful is if you could go through the old report and kind of tell the committee what's still needs to be done and what's already been checked off, because not all of us were there in 2007.
The staffing issue, retention, not only retention, but attracting and retaining is still a major issue. Now, we have what, compared to back then, the number of EMTs and paramedics in the state is a lot more than what it is in this report. It was at about 12 or 13,000. We're about 24, 25,000 now. But we've grown as a state rapidly over that year. Again, back then, Habersham was running 2 ambulances. They're running 6 now. So, you know, you had to have increased staffing. So the staffing and retention, the education is an issue. I know Liz has talked about still in the rural areas. Here, we're very fortunate with Northeast Georgia, a great trauma center, stroke center, and cardiac center. But you get down below Atlanta and get in some areas. If it's not a pretty day and you can't be flown, and you're in acute trauma, it could be 2 hours before you get to that trauma center. So those are the major ones, is staffing as far as attracting and retaining. Same thing that the nurses industry, the physicians are going through. Our education, we've got to get it spread around the state on the technical level better than what it is today. And then we've got to look at some kind of retirement plan that we can do that's a carrot to it. It's not going to benefit anybody like me or people that's been in it a long time, but we've got to find something that's a supplemental retirement like law enforcement and firefighters have for EMS. And that's probably going to have to come from the federal level or some help from them.
If I may, Mr. Chairman, one follow-up. I'm concerned about the test failure rate that you talked about. I'm serving on the Joint Defense Commission, and the military has run into the same thing with their testing. They've either got people who can't pass for whatever reason, or they can't pass a drug test, or have some other disqualifying thing, obesity or whatever. And I imagine that the same people that are thinking about being an EMT or paramedic are also thinking about other health sciences. So what's the difference between the testing, and how can we address that?
That's a good question. I know the Office of EMS and Trauma has worked on some things and looking at different things on the education level and what the problems have been. There's been some data put out, but I don't have access to that data. That would need to come from Michael Johnson, who's the OEMS and Trauma Director in his office. But some of the issues you talked about are some of the same ones faced in that too. Absolutely.
Yeah, let me jump in real quick. So we had the executive director for the Georgia Trauma Commission here earlier this morning.
Mm-hmm.
Yep. And she was testifying earlier. And I asked her specifically in regards to South Georgia and the time it takes for a patient who is injured on I-75, for example, to get to a trauma center. I asked her, should we focus on building new trauma centers in more, I guess, strategic locations in South Georgia, or focus on bettering the transportation for trauma patients to get to the care centers? And she said transportation and more focus on EMS. Do you agree with that? And if you do, what do you think we could do as a state to help specifically in South Georgia, where, you know, in North Georgia we're closer to Atlanta than we are, and we've got Greenville and we've got Chattanooga, but in South Georgia there's places where you're 2.5 hours from
That's right.
the hospital,
And
at
most,
least.
correct. And most of those, and I totally agree with Liz on that. And the other thing that most of those rural areas are small rural communities that doesn't have a hospital, or they've got a small hospital. So when they leave with that ambulance, that may be the only ambulance that community has. So now they're gone on a 2-hour transport, and that's 2 hours back. So 4 or 5 hours they're gone and no coverage, or backup maybe in that. But if it's a major accident and they're all gone, there's no coverage in that county. So that's another issue. Again, we run into, because we have private services that provide great service, that's, you know, if a county chooses a private provider to be their zone provider, that is what they chose, and that's okay. As Jim said, we represent the privates and county, cities, hospital, all. We don't differentiate between any of them. But that does create issues when it comes to talking about retirement or state funds going to help something like that when you've got private providers in it. But we've got to find a way to include them. We can't exclude them, because most of your county services, overall, the Gwinnett's and Halls and large ones, they don't do the transfers from hospital A to hospital B. They don't do the patient discharges. You have to have those private providers that do the majority of that. And if we don't, it would completely collapse the system. So we've got to find a way to help get salaries up. We've got to find a way to get better education. And we got to find a way to keep people wanting to do the job. I mean, we've been hearing law enforcement bad, and they've got a huge issue too, but we're in the same boat. Doctors, nurses, EMS.
Thank you. Senator Jackson.
Thank you. I have a few questions. One, last year we heard a presentation from somebody down at Mercer about people who are incarcerated who are trained as firefighters, and the ways that they are saving lives in rural Georgia because they're firefighters. What can we do to get those folks cross-trained as EMTs as well?
I've addressed that. Georgia, you go through EMT school, paramedic school, and then Georgia, back when I took years ago, had their own test through the Composite State Board of Medical Examiners. Now it is through the National Registry of EMTs. And they're not going to allow that. One of the girls, that Alto here, the ladies' prison here, provides fire services. Backed us up. Those ladies were phenomenal. Going to Tallulah Gorge with us on gorge rescues. One of them I couldn't hire at the time, but we helped get her a job in White County. She has made a tremendous turnaround, and we just helped her to get a complete pardon in National Registry accepted. She passed her EMT, and she's working here in Habersham part-time too. So that, I wanted to go down to the prison at that time and be able to put them through EMT school. That was part of the fire department. So when they got out, they was ready for a job, but National Registry does not allow that.
And so that loops back to us no longer having our own certification system, which maybe we should look at that.
There's
I
good
mean, there's
and bad
pluses
to
and
both.
minuses.
There's pluses and minuses
I think
to
being
both,
nationally boarded is really important for those
Mhm.
who can be boarded, but if we want to expand our pool, that might be an option. Secondarily, I'm also interested, I know that a lot of fire service is provided across the rural Georgia through volunteer firefighters. Is there an effort to recruit them to be cross-trained as EMTs as well?
Well, a lot of them are in those areas. They're at least medical first responders, and some of them are EMTs. And those are vital. Those first responder programs are vital, especially in the rural areas.
Yeah.
And that's a lot of what you see, Senator, is the fire going out. You know, as I said, EMS that has the zone to provide 911, they have a duty and an obligation to respond. Fire departments that do not run EMS, they have a desire to first respond, and that's the right desire. But we're going on a lot too many calls. We're sending those fire apparatus on calls that probably sometimes an ambulance really shouldn't even be going on. And we're going to have to look at, throwing all these resources. We're going to have to look at a tiered EMS system. Some places are doing it. Grady does it, Clayton County Fire, where you match the 911 call through EMD at the 911 center. You triage it there, and you send the appropriate level of care to the call. You don't send a paramedic. In reality, a paramedic probably needs to go on less than 15, 20% of the 911 calls that come in.
And then one final question. So I know in a lot of our high schools, we've created programs where you can get licensed as a cosmetologist, as a CNA. There are all these pathways. How do we get EMT as a part of that?
Right before I retired, we started that in Habersham, and Chief Adams has taken it. They should get their first class out through cooperation with North Georgia Tech and be EMT firefighters if they're 18 and they've been able to take their exam.
Of course.
But, and the thing I hope, and I want to come back and see it, is that when they get their high school diploma, Chief Adams is waiting at the bottom of the steps with a job application for them and keep them, we kind of called it homegrown.
That's
So
right.
working with Habersham Central, and that program is active here now. Clayton County has a very robust program down there. Chief Murkison did a great job starting that.
That's great.
the fire department there?
Through Clayton County Fire, yeah. Chief Murkison started it. He's in county administration now, but he's at the bottom of the stage, or was offering job applications, and they knew he was going to work. So when they graduated, they were going right into the fire and EMS. So we're looking at there's some things that's been worked on like that, but only a few areas are doing that. So, and it's a heavy lift to try to do all that and provide the service too.
Sure.
But, we're looking at all options. So again, I appreciate the time.
And it just could, one question.
You got the microphone.
We've heard a lot of infusing addressing the situation with paid scholarship, paying for the training, it's investing in the students. And how much of that are you seeing happening with
Well,
the
a lot of the
EMTs?
younger ones can get HOPE, which is a great thing for this state to go to EMT, but paramedic school. But the problem is once they go through EMT school and some of them exhaust all of their funds and they can't get it to go on to that post-education if they want to get their degree or anything like that. They use all of that for EMT and some of it for paramedics. So a lot of that is being used now for older ones that want to get in. There's people that's wanting to get into the business. Sometimes they're not eligible to receive that, or somebody that started one career as far as using their money for that and then decides to change. So it's a cost issue too. It's very expensive to send them to school.
But that, it turns out that's what's working.
Oh, yeah.
Yeah.
Absolutely.
So pursuing that approach. Thank you.
Thank you.
Any other questions? Thank you, Chad. Thank y'all for coming today. I think this has been very productive. Y'all are here because you care. There's a lot of smart people in the room. I would encourage you, if someone in another area came and testified today that you may have heard something that you think could work, I would encourage y'all to collaborate, reach out to each other. If you need someone's contact information, please reach out to John or Bernita and send us those ideas. As we move along in this process, we're going to limit what we're looking at moving forward. But if there's anything that really stands out that you think, hey, we could make a difference here, please don't be shy. This is why we invited you here, and this is why you're in the room. So Just thank you again, Northeast Georgia Medical Center. Thank you for the committee members, Bernita, John, y'all did a great job, and thank you everyone for attending. I think this has been very successful, and I technically got us out 13 minutes early, so thank you guys. Thank you.